Live in 10 seconds, please.
Good evening, good evening, good evening. Good evening, everyone, and welcome to AIOS Scientific Committee, Treat Cataract and AMD Case Files. Thank you very much for joining us this evening, and it's my pleasure to welcome all of you on behalf of our Governing Council of AIOS, and it's a pleasure to introduce to you our team, Scientific Committee, Dr. Amit Porwal, Dr. Fairuz, Dr. Jatinder Bhalla, Dr. Krishna Prasad, Dr. Parikshit Gopte, Dr. Somshila Murthy, and Dr. Sonu Goel. On behalf of Team Scientific Committee, today we present to you Treat Cataract and AMD. Welcome our chairpersons, Dr. Mahipal Sasdev, President AIOS and Chairman of Scientific Committee IRSI, Chairman and Managing Director, Center for Sight Group of Hospitals. Welcome, sir. Welcome, Professor S. Natarajan, the Evergreen President of AIOS, immediate past President AIOS, and Chairperson and MD of Aditya Jyot Eye Hospitals. Welcome, sir, Dr. Lalit Verma, Vice President AIOS, Senior Consultant, Center for Sight. And welcome, Dr. Shobhit Chawla, sir, Medical Director and Chief Retina Surgeon of IQ in Lucknow, President VRSI. Thank you very much, sir, for being with us today. I would request Dr. Amit Porwal to introduce our panelists. Dr. Amit.
Yeah. Good evening, everyone. Welcome to this scientific webinar on cataract on AMD. So we have an expert panel over here from all over the country. And now I'm going to start introducing a brief introduction of our panelists. So we have Dr. Rajiv Chaudhary. He is the Director of Rajas Eye and Retina Research Center from Indore. He is a well-experienced cataract surgeon, and we welcome him for his inputs for this particular webinar. Our next expert panel is Dr. Hemant Murthy. He's a Senior Retina Consultant at Retina Institute of Karnataka in Bangalore. Welcome, sir. We welcome you for the scientific webinar for your expert panel opinion. We have Professor Namrata Sharma, Secretary, All India Ophthalmological Society, Professor of Ophthalmology, Cataract, Cornea, and Refractive Services, RP Centrally. She is one lady who does not need any introduction. She is heart of all the webinars which are being conducted by AIOS. Welcome, Dr. Namrata, ma'am.
Thank you so much.
We have Dr. Mohan Rajan, who is the Chairman and Medical Director of Rajan Eye Care Hospital, Chennai, surgeon par excellence, and who is also known for his vitals. So welcome, Dr. Mohan Rajan, for this webinar. We have Dr. Malika Goel, who is a Senior Consultant in Retina, Vitreous, and Uveitis at Apollo Health City, Hyderabad. Welcome, Dr. Malika, for your expert opinions as a panelist in this webinar. We also have Dr. Nishikant Bose, a Senior Veterinary Retinal Surgeon. He's a consultant in Insight Eye Clinic, Mumbai. Welcome, sir. And we have Dr. Ajay Paul, Director, BB Eye Foundation from Kolkata. Again, a great cataract surgeon with huge experience. Welcome, Ajay, for the scientific webinar. I need your expert opinion for your panel as a panelist. So, not taking much of a time, we start with our first presentation. Partha, should we start the first presentation, or we welcome Dr. Mahipal and Dr. Namrata? Some comments as an opening remark?
Yes. So we request comments from our chairpersons.
Mahipal, sir, you start. Mahipal.
Yeah. Thank you very much, Dr. Partha, and thank you very much, Dr. Natarajan. Again, we are coming to a very nice webinar from the scientific committee. As I've been saying all along, that this scientific committee is really consisting of great people who have really worked very hard to establish themselves in the field of science and ophthalmology in India and abroad. And they pick up the topics very, very nicely. And I think this is one of the topics that is of great importance, where we have a common age group and a common symptom of painless progressive diminution of vision, that is cataract and AMD. And obviously, it's a dilemma with the ophthalmologists, specifically people who are possibly not trained in retina and not having a retina backup in single practices, having a patient coming with these problems as to how to manage them. So I congratulate the scientific committee for having put out these many experts who are good at both cataract and cataract and retinal surgery and retinal diseases. And I look forward to a great webinar which will be looking at this common problem that most of us face. So I think without taking any more time, we can have the session started. Over to you, Partha, and Dr. Natarajan for his comments. Thank you.
Natarajan, sir.
Thank you, Maipal, and thank you, Partha, for this session on AIOS Scientific Committee case file street, cataract and AMD. And generally, when I remember from the 88 when we started treating both cataract and AMD, I always tell the cataract patients that whatever cataract is blocking, that much vision will improve. And whatever the retina is blocking, maybe due to AMD, will not improve. So I think it's an important thing, both in the angle of the patient, as well as the cataract surgeons, and how cataract surgeon and retina surgeon, whether you're working solo or together, to do this. And with this, and off to you, Dr. Partha, for a wonderful session.
Lalit, sir, your comment, sir.
Slight modification in what Natti said. Retina also can improve, Natti, now. I think Atul will clarify this. Retina also can improve. What Maipal used to tease us every day, retina wale vision chart apni jeb mein leke chalte hain. I think Atul, the chief of IPN, will dispel this, that this is no longer true. You see, initially when I saw this program, you see, all of you treat cataract and all of us treat AMD. So what was so different treat cataract and AMD? So initially मुझे समझ में नहीं आया. So when I read in detail, so Partha is very carefully, this vibrant scientific committee which Maipal was saying is so vibrant and exuberant also. All the 6 case presentations are by retina guys. And discussants are a mix of retina and cataract. Partha and Amit Porwal, they are smiling because they are the brain behind this program. And each talk has AP consultants, anterior segment and posterior segment both. Because I think cataract people want to extract the maximum out of this. But if cataract AMD इकट्ठे हो गए, तो कैसे बचें वहाँ पे? Because they can't rush for cataract surgery. What are everybody afraid of? But retina should not progress after cataract surgery, and patients should keep praising but cataract surgery बहुत अच्छा है and 6x6, because in such scenarios cataract surgeons are unable to get 6x6, 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 which they are very fond of, telling everyone. So hence I congratulate the entire vibrant, exuberant scientific committee for crafting this program, brainchild of Partha and Amit Porwal. I know this, that you see, this will throw a lot of light for all the people, combined cataract and posterior segment people, that how to approach such scenarios. And I've seen 6 case presenters after, we hear the chief about the neovascular AMD. Congratulations, Partha and the scientific team, for a very nice crafted program.
Thank you very much, sir.
Waiting to hear.
Dr. Shobhit, sir, a few words from your side.
Thank you very much. Great program. And taking Dr. Lalit Verma's thought wave forward, I feel that we are managing both very well today with the newer modalities of treatment. And at times you are advising early cataract surgery to be able to manage the coexistent AMD better, maybe investigate it better, maybe treat it better. I think in the present era, it's a very relevant, and in the COVID era, it's even more relevant, as one of the presenters is presenting in a slide where examinations can be very cursory in the fundus because of a lot of concerns, and OCT and other investigative modalities can play a great. Thank you. Look forward to a nice, invigorating session.
Thank you very much, sir. Thank you very much. We'll move on, and we have today with us as our keynote speaker none other than Professor Atul Kumar, sir. We are really glad, sir, that you are with us here today, and you have spared time from your very, very busy schedule and sir would have to leave after the keynote address. So let's get the best of him, and the lecture that he is going to share with us today is going to be, as usual, his par excellence lecture. Thank you very much, sir. Professor Atul Kumar is the Chief and Professor of Ophthalmology at RPC, at AIMS, the National Apex Ophthalmic Center at All India Institute of Medical Sciences. He was awarded Padma Shri in January 2007 for his services to the medical field. He specializes in vitreoretina surgery and also heads the vitreoretina, uvea, and the ROP services at RPC. And as we know him, not only he is an excellent clinician, but a teacher par excellence. So whenever we hear Professor Atul Kumar, it's a talk that we remember for lives. Thank you very much, sir. And we request you to give your keynote lecture, sir.
Thank you, Partha.
Yes, sir.
Sharing screen. So I'll start.
Yes, sir.
Yes, sir.
Okay, so I'll go through my lecture, and I hope I can pass the message which I have in my mind across. And we take things like AMD very lightly. For years together, for decades together, we faced this problem of AMD more in the West, but now there's an aging population in India itself. People crossing 70s, 80s, going into the 90s. So it's common in India, which wasn't so few decades back. So it's become an enigma how it happens. What are the kind of presentations? What variants are there? I mean, what you don't expect happens, and all of this I just put together in a lecture. So I thought I'll just share with you that this is not a very easy disease to treat. I mean, not so tough also, but it's not just anti-VEGF and that's it. So it's the biggest problem is it's increasing blindness, because as Maipal and Partha also said, and everybody, that there's increasing aging population, and if you go to the there's a increased prevalence of the aging population. Global prevalence is about 8.7%, and there's a good 50% increase.
Sir, slide share is not done, sir. Excuse me, Atul, sir. Slide share is not visible.
Yes, sir. Okay, 1 second. Now it's...
Yes, sir.
Yes, sir. Now it's visible.
Yeah. So you got a global prevalence of AMD about 8.7%, but it's going to increase. Like diabetic retinopathy is a little lesser age group, but AMD is something which is a silent blindness. Diabetic retinopathy, you have systemic symptoms, you have ocular symptoms. Patient comes with floaters, this, that. The AMD doesn't have floaters. It's gradual loss of vision. It's painless. Diabetic retinopathy may have, today only I saw in OPD, there was iris rubeosus frank. So people don't know what is iris rubeosus. It leads to neovascular glaucoma, and then because of the lockout period, they lost their vision because they never ventured out of the house since February, March. So with the aging population, India is going to have a problem. We've had a AMD study, and they say it's similar, but grade 3 appears to be lower. But this could be fallacious because, as was mentioned by the President AIOS also, that there are difficulties in testing for retina. It's easy to test for cataract, even in a RAB survey. RAB survey is a selected survey in a population. The RAB survey is a quick survey to find out what's the prevalence of a particular cause of blindness. But its problem with AMD is that you have to check the retina. You have to have trained people. So we have lack of trained personnel for retina. You have lack of resources like examination, imaging techniques, because whatever said and done, FA, ICG may be required at the primary health or at least the secondary health centers. You might require an OCT, which is very, very important, and OCT-A also. And if you have the same machine incorporates autofluorescent imaging, it's better. So you've got a multimodal imaging system where you can do all these tests. Only then you can actually define whether it's neovascular AMD or dry AMD or something else. It's not AMD, it's something else. So it's very important. And therefore, I think we don't have the requisite personnel, the imaging techniques, and And often we don't know what's the cause of visual loss because we just say it's aging and it's probably choroidal sclerosis or the nerve is not improving. 618, 624, it's fine. But actually maybe having a gross AMD at the back which progresses because of the cataract surgery. And there's a lack of awareness. So though the classical pre-AMD drusen are this way, but there is another thing called pseudo-drusen. And pseudo-drusen are present above the RPE and they present with these sharp elevations. And it's like a net. It's like a net all over. It's not as diffuse. Drusen is not as diffuse as the pseudo-reticular drusen. They also predispose to a lot of AMD. So you got to see both these things together. You have to know these things. So personnel have to know this. Now, sometimes, you get a picture like this in a patient and you check for cataract and it's there and you think it's probably diabetic retinopathy. You get his sugars, it may be still normal, but still. So it's very important such patients get their OCT done if it's possible through the cataract. You'll see it's not a diabetic maculopathy at all. It's not a sursnet ring. It's got a PD, fibrovascular PD with multiple PDs along with it. And it's got serous fluid. It's actually a wet neovascular AMD or a polypoidal choroidal vasculopathy. And the same patient showed the branching vascular network and probably a polyp over there. So both eyes are presenting with a picture akin to kind of these exudates, hard exudates. So hard exudates is actually a picture not only with diabetic retinopathy, it's also with neovascular AMD. So you can have, this is a picture of a patient which was very shocking and surprising to me. He was doing very well. This was his state in May. He had a type 1 CNVM sub-RP, there's a little double layer sign, and he was doing well. I told him that we've had your injections, we'll wait. This was his octa picture, OCTA. You see the huge neovascular network going from the superior arcade vessel, main temporal vessel, to the inferior. So I didn't give much importance to it. There's no fluid, so I'm not going to treat. He came back within less than a month with the bleed, and he had this neovascular AMD, of course, was there. And this was the RPED, which came up from here. And you can see the subretinal hemorrhage all over. So he actually lifted up his fovea and his vision went down to hand movements and he was grumbling, cursing, what happened? So what I realized is not only the SRF is important, but now I take OCTA into absolute consideration. So we'll have to take the OCTA and check for the size of the neovascular membrane. I don't have guidelines right now, but I feel a large neovascular membrane on the OCTA, which is non-invasive, very acceptable to the aging population, may be the guideline in future also, not only the subretinal fluid, but also. So what happens is when you have a neovascular membrane and you have this PD and you have probably the occult type of a CNVM, you have these deposits over here and you have these deposits after you treat it. Now don't ignore these deposits. There is something called SHRM. This is subretinal hemorrhagic. These are small deposits over there. It's a hyper-reflective material, and they actually tell you that this patient has a relatively poorer prognosis to anti-VEGF. He's going to end up with more chances of foveal scarring. So SHRM or subretinal hyper-reflective material should be looked for. Now, these things are very important because the prognosis of the patient depends on it. So this is a unique thing which is happening, that these are markers which tell you. Now, there's another very interesting thing which is happening recently from New York. They've reported this, and it was actually reported in 2014. But we've got to look for it. There's a multi-layered PED in neovascular AMD, and I'll show you the picture right away. This is the multi-layered PED, and it's got a choroidal cleft. This choroidal cleft is known to be present in patients who receive chronic anti-VEGF therapy and they have a fibrovascular PD. So you can treat again. So this is a chronic fibrovascular PD with a choroidal fluid over here within the choroid. Now, sometimes when you give chronic injection, this is two things very important, which from the point of view of cataract surgery also, that this patient had cataract. He wanted to get his cataract done for dense PSC, but he had this at the back, choroidal cleft and multiple injections given of fibrovascular PD, and he had a rip. He had a RP rip. This is an enigma. I mean, we don't know why these rips occur. They occur spontaneously. If the height is more than 500, the risk goes up. The height of the RPD, the fibrovascular PD, the height is more than 500. Less than 500, 400, they say it's 10%. 600, it's more than 40, 43%. So with anti-VEGF, they say the risk goes up. And that's what's been reported, that if you give multiple anti-VEGF injections, like this patient received multiple injections, they suffered a rip. So he said, my vision is distorted. I'm not happy. I'm not happy in this side. Other I am happy. You see the RP rip on the Octa and RP rip on the FA also. So the same rip which is seen on the clinical photograph is there here, and actually it's ripped here. So you have multiple problems. You have a multi-layered PED, fibrovascular PED. You do the cataract, he may bleed. And you've got a patient who's not going to improve vision. He's going to have distorted vision after the best of cataract surgery because he's got a rip. So these are the things which are very important that we have got to see along with cataract surgery. So these multi-layered PEDs, we just kind of looked up the literature at RPC, and so we found that these fibrovascular multiple bands have contractile properties, and this, when they shrink, when you give multiple anti-VEGF, the vascular component shrinks and tears the RPED, and you get this prechoroidal cleft. So this is what happens: is a type 1 CNVM, and you have multiple under the PD. You have a type 1 CNVM. You have multiple fibrovascular tissue, and this is a choroidal cleft. This is another case of ours. So we're looking at this more carefully now. You can give them anti-VEGF, but vision-wise, probably they won't improve much, and they can bleed also because they're fibrovascular PD and they can rip. So RP tears are very important. They can occur, and we have to know this. Even cataract surgeons should know this, that if you inject repeatedly in somebody who's got a pigment epithelial detachment which is high and tense and like a bleb, like a, you get warm fluid on your liquid on your skin, you get a bleb. So if you got a high bleb, you might get an RP tear. And this may happen during cataract surgery also, because it is known to happen spontaneously. The PVD occurs and you may actually create an RPD, and the patient may get worse vision after cataract surgery when he actually had better vision. So you'll have to discuss all this. This is another patient who had cataract, and of course he had a choroidal cleft here. So I won't go into this. The first line management, of course, is anti-VEGF. Either give it monthly, treat and extend of Pro Nata, or treat and observe. Treat and extend will become very popular. And this is a neovascular membrane, and it's probably PD and fluid, and we treat. And this is what happens usually. We treat with anti-VEGF, there you are, patient is fine. Either you do PRN dosing as and when required, or you do treat and extend. Some people for a PRN, so it depends on what. Come back for 1 month for OCTA, and probably now OCTA. So this is the usual what we do. But it's more than that. You actually have to see how often do you want to see the patient who's suppose operated for cataract. This is post-cataract surgery. Even then you will have to be careful, because you're the one who operated the cataract surgery. So he's going to be talking to you also. He says, now my vision has dropped. What's happened? So you've got to have a retina consultant with you, a retina specialist who's really good at looking at the macula. Because periphery is fine, but macula, looking at the macula and looking at AMD is not a kid's job. AMD is easy to see and looks very easy, but actually it has a multiple complexities with it. So like I said, RIP is one of them, and multi-layered PD is one of them. And you can have a no fluid large CNVM on a OCTA. So OCTA, I think, has become necessary. So this is an Altair study done in Japan only, treat and extend, they found. In AMD 2 and 4 week extension protocols, that means once you treat after 4 weeks, you don't treat if he's fine, and then give them 2 weeks gap or 4 weeks gap extensions. They found they were both equally effective. So these are some studies. A choice, of course, for a cataract surgeon, he's got to charge for that, and then he's got to there will going to be charges for the anti-VEGF also. Ranibizumab is effective. For this slide I'm talking, and bevacizumab is also effective. It's slightly economically cheaper, definitely. But there's a problem with bevacizumab. It's not a single dose. It's multi-dose ampule. The risks of cluster endophthalmitis and compounding issues are there. Even in the US, they've had scattered issues of compounding and infection occurring even in a place like US. So there is a little risk with bevacizumab, but of course, at RP Center, we create our own ampule. So, but of course, it's a problem. But most of the studies, the CAT was the main study done in the US. IVAN was the UK counterpart, MANTA, GFAL, UCAT, just to complete the literature. Bevacizumab was not inferior to ranibizumab for AMD, neovascular AMD. So the CAT study showed that it was non-inferior. But serious adverse events occurred at 24% for Avastin and 19%. The Avastin showed more serious side effects, besides the risk of endophthalmitis is there. So the aflibercept is added to the armamentarium, and we've got a VO1, VO2 study which showed us, because these trials are very important. They tell you if something happens, you can tell the patient this is the trial, which actually showed us that aflibercept is effective. So aflibercept really acts very well on neovascular AMD, especially polypoidal choroidal vasculopathy. It's a comparable injection to ranibizumab or even better. And this is brolucizumab, which has recently been introduced. There's a lot of controversy if I say anything about it, because it's a low molecular weight, very high penetration into the retina. There are 2 studies which have actually shown that it's non-inferior to aflibercept. Aflibercept is the most potent anti-VEGF we have now, the brolucizumab also. So we need to have, the cataract surgeons have to have this basic knowledge that there is brolucizumab now introduced in India, but there's a big but here. AS, American Society of Retina Specialists, have shown there is a 4% increased risk of inflammation, which is 1% for aflibercept and 4% for brolucizumab. Second is they've seen 14 cases of occlusive retinitis. So that's 1% of patients. So that's going to be a little, elephant in the room, because you don't know if if the patient falls into that 1% or 4%, he's going to be troubling up the doctor, and he's going to lose his vision. We get occlusive retinal vasculitis, he's going to lose his vision completely. So the issues with the anti-VEGF therapy, don't take it lightly. Anti-VEGF, before cataract, after cataract, okay, it's fine. But the thing is, the duration is very short, and 30% lose vision despite the anti-VEGF. That has to be told due to inadequate response, or there is for progression to fibrosis. So either response is less or there's a response. So it's easy for Novartis or Bayer to say that, we give this injection, we give that injection. But what is going to happen with those injections? Either you get the vision may not improve at all. So many patients come there, visions are not improved. In fact, the quality of vision has gone down. More than half of them, the quality of vision is very important. I can't see contrast. I can't read my book. 70-year-old man, 80-year-old lady, she's going to want to read something. She wants to watch TV, but she's not having the vision. So finally, what do you bank upon? It's a big problem. So the burden of treatment fatigue with anti-VEGF is there, and some opt to discontinue treatment. I'm not going to talk about this. I come straight to this variant. Again, we have an enigma. Neovascular AMD has a variant which is very, very menacing and present in the Asian population, Japan, Singapore, Taiwan, and India. I won't name China because we all know it. So polypoidal choroidal vasculopathy is a problem which is seen in the Asian ancestry. It's either a standalone variant, a lone entity, or it's a variant. Most people think it's a variant. And it's got features of pachychoroid, thick choroid, and it's got PEDs like you saw in the previous OCTs. It may masquerade as CSC because initially it may present with anxiety, lack of sleep, and that leads to CSC, central serous choroidal retinopathy, or CSR, and that leads to PCV. So this is the kind of a picture you can get, patient comes to you with blood, he may be having a cataract. So you got to get the macula examined, and you may have actually polyps over there. And these kind of patients have multiple PEDs, and they've got this subretinal exudative fluid over here, and the hemorrhage also with the hemorrhage. So these are kind of patients, you have to treat surgically. If the macula is off and the vision is affected markedly, then you have to treat anti-VEGF. So this is another patient of PCV. You can see the polyps, which are classical, and you've got this branching vascular network, multiple polyps. And you see the classical thumb-like PED with the multiple thumb-like and a notch, and you've got subretinal fluid. So these are type 1 neovascularization with PED, and this is classical. And this is another patient with polyp, which actually got shown on the Octa. Octa picks up high flow lesions, but the polyp is a low flow lesion, picked up an ICG best. But here because it was so large, we did the manual segmentation, and we could pick up the polyp on the Octa also. So you have to have the OCT, and so I won't go to these trials. The photodynamic therapy is one thing which works in PCV. Luckily, we still have that dye because Novartis is withdrawn, left themselves from the dye. They've given it to somebody, I don't know who. Each time I ask them, you're marketing brolucizumab, but tell us what is happening to the photodynamic dye. Because photodynamic dye is vision, it prevents blindness. It is very, very important to have photodynamic therapy. And they have to answer for this, because I'm talking in front of the AIOS because we need this dye very badly. And without this dye, the PCV patients may actually bleed finally, and they're either going to spend every 43,000 rupees cost price for anti-aflibercept. And PDT actually cuts down the number of injections, and plus it improves vision also. I've seen so many patients with my personal experience. So we've got to have photodynamic dye, which is not forthcoming from the Novartis people. It's a big problem. So this is another, RAP is another lesion which is a variant like PCV. It's type 3, that is intraretinal neovascularization, and you got intraretinal fluid and you got a PD. So I'm just not going to detail of this. So these are newer things which you are seeing, the port delivery system, ranibizumab. But it's like a ganciclovir intraocular device, which was earlier, right in the beginning, it came out for CMV retinitis. So I don't know how many people would like to have a port made and put this, device inside the eye. It may lead to endophthalmitis, it could lead to ardent detachment. But anyway, this is one of the things. Now, this is one of the most important slides I want to tell you. Only anti-VEGF is not going to help our patients. Please, you have to have the anti-angiogenic drugs. Anti-VEGF will only inhibit the VEGF-A, all the isoforms. So now they're targeting the angiopoietin. The angiopoietin pathway is totally different, the Ang-Tie signaling pathway. And Boulevard study and a couple of other studies which is coming up, there's a drug called faricimab. I don't know who's going to market it finally. But faricimab is a one molecule, two targets. It's like kill two birds with one stone. So it's got anti-Ang, anti-VEGF. So we could eat something like this, because what it does is it destabilizes the blood vessel so that the anti-VEGF can act very well. So we need something like this. As long as it doesn't cause intraocular inflammation or occlusive retinal vasculitis, we could be very fine with something like an anti-Ang. I have no proprietary or any kind of financial interest in any of them. These are all in trials. There's a phase 2 trial on. So this is one molecule. All these trials have been done in the US. Let me tell you anything. Nobody to beat the US. All our latest material is coming from there. Whatever sent on the medical material or the ophthalmology material is the maximum from the US. Okay, so gene therapy is going to be there, target immunotherapy, stem cell therapy. Basipar was being developed by Allergan, but FDA has refused. They've said the risk-benefit ratio is very low. There are more risks than benefit. It causes, again, occlusive retinitis. It causes intraocular inflammation, like brolucizumab. So they've refused granting permission. So we'll have to look for something which is combination of this two, because until you don't block this anti-angiogenic pathway, Ang-Tie 2 pathway, it's not going to help. So this is the last thing which I do very often. I've done about 200-300 cases. So whenever a patient of bleed comes, like the patient who had a huge CNVM, but no fluid, blood hemorrhage. This is a smaller CNVM, but fovea was involved. So I'm just showing a small clip of 5 seconds before I end, that this is what I do. I create a PVD, then I inject with a 41 gauge cannula. I inject a recombinant TPA at the concentration of 12.5 microgram in 0.1 ml with Avastin, double dose, 2.5 milligram, plus a little bit of air. So you can see I do the IOCT to see where the PD is not there. So I don't go sub-PD, I go subretinal. And from there, I just create a big mound, which contains some little blood will come out, because that's the blood over there inside the subretinal space. With this is the air finally. So this is the kind of mound which comes in, and the patient sits propped up, and the results are very good. So these are unmet needs, high burden, transplant. Patients got very unhappy. He's going to come again and again for injection. So we want, this should be a longer acting injection or more effective injections. This is the kind of picture which we get finally when you treat patients for long. You come up with scars. And this is just telling you that gets, very bad. And subretinal fibrosis are very high. And this is the final slide, that this is a very important thing. When today only that same patient told me, the subretinal bleed patient who had a large octa CNM, can I use some magnifying aids? I'm very fond of reading. So these assistive devices, assistive technologies would be very important till such time that we have something. So right now we don't have a magic cure or effective cure at all for AMD and for neovascular AMD. And for dry AMD, of course, the visual loss is very less. They can be managed. But neovascular AMD, visual loss is profound. So with cataract, we have to see the macula very well, especially for AMD, and try to, understand many of these things which I've just discussed. Thank you very much. I hope I haven't crossed up time too much.
Oh, sir.
Thank you, sir. Thanks
so
a lot
much.
for the wonderful talk.
Sir.
We have the discussants now, Dr. Mahipal Sachdev, Dr. Natarajan, Dr. Lalit Verma, and Dr. Shobhit Chawla for the keynote address of Professor Atul.
Thank you, Atul, for a wonderful briefing on the AMD and all the varieties you showed, the mimicking AMD as well as the PCV, and also masquerading of CSR, the role of PDT. And I think it's really amazing. And in case I think vetoporphyrin is not available, maybe we can think about the ICG. And
we need vetoporphyrin badly.
Yeah, and all the ICG guided.
How will you treat a PCV case? Repeated injections you'll give. After that, there'll be a stage when you like to do a photodynamic therapy. The dye is not there with them now.
I know. I think this is a problem with the commercial companies. I don't know how to. Maybe AIMS can do something, or a RP Center can do something.
They don't
Of drugs. No.
They won't
Okay.
listen to me.
I think it's good.
We'll listen to AIOS.
Okay. Good homework for, I think, Namrata and Maipal. But I think the best thing you brought out is about all the latest things on, including the future drug, which is not
the anti-angiogenic drugs.
Yes, and it is very good.
VEGF is not the only answer. There's another pathway, angiopoietin pathway. So that's not inhibited by any of the anti-VEGFs.
Correct.
I think the way forward will be an anti-VEGF and an angiogenic combination. If we are not going to have PDT, it will have to be a combination. Maybe something as a sustained release implant and something as an injection. That's what comes to my mind, seeing the severity of the PCV cases and the numbers we are now identifying more and more in our country.
Absolutely.
And I think the other thing which you said is, which I always tell the fellows in my hospital, that they're treating AMD and finally you dry it out, or maybe after a few years, and don't say that the whole disease is gone. Make sure the patient comes for follow-up. And I think you rightly pointed out the last 2-3 slides about low vision aid. And I think it's important, where I tell the patient that you can bring down to 636 and give them a LVA. They can even have 6.9 in whatever restricted way, as well as the N5 using the various types of LVA. And I think it's very important. And I keep telling my optometrists that you should spend more time, and even the fellows, and encourage the patient, because don't compare what you had 10 years back and I want to read and I want to say my like it, but still you can use the low vision aid and do your work, sign your checks, and keep abreast with their knowledge. I think wonderful, Atul. I think as a vitreoretinal surgeon, people otherwise think we only do treatment and surgery, but I think you have rightly pointed out to the anti-segment surgeon that when a patient has low vision, send them to a low vision clinic or to an optometrist and make sure they see better. And I think it's important because there's also a trial of intraocular lens for AMD patients with the telescopic intraocular lens, but it didn't do well. I think cataract surgeons were doing it. But I think finally, I think we have to probably prepare the patient that it is a lifelong disease and you have to keep checking. And as you rightly said, it's not an easy disease. Same time, it is not to give up. But I think the cataract surgeon also probably should expect, as Lalit said, there is definitely an improvement possible. I think when the cataract you do, and make sure that the patient comes for follow-up. And I think many times it shows that as though we are soliciting patient to come back. But I think they have to understand ARMD is related, and they have to keep coming to the doctor.
Amsler grid can be given to them.
Yes.
Amsler grid for screening.
Right. And that's why I have a first Amsler garden in the world, which is a vertical garden in the hospital inaugurated by Neil Bressler. And I keep telling, and I make it a point to give it, and also had that the PHP. But it's not, again, the sites has stopped making it, and the US tried making as a nodal company from Israel wanted to do a home monitoring using the PHP for monitoring, but it's expensive. But I think the simplest is the Amsler, and every patient forgets to use it. I always tell them, put it on the mirror when you go to do shave, cover one eye and check. It takes only 5 seconds. And I think every anti-segment surgeon can tell that, so that both can have patients. I know Professor Atul is in the institute, but it's not only getting patient, but I think we're helping the old patients for seeing better. And I think he put a slide on QOL, quality of life. And I think there are a lot of studies both in India and abroad, and Arvind has done it. And I think cataract surgeons have to help that quality of life can be improved in an AMD patient. Maybe he'll have color contrast problem, but if he has a regular treatment, I won't tell, I have a VIP patient who's coming for almost 16 years every month, very meticulous, and that's why one eye is maintaining 6.6 and other eye is 6.36. He said my left eye is gone, but I said no, 6.36 to maintain. I'm still giving you anti-VEGF injections.
Right.
Thank you very much, sir. Sir Maipal, sir, from the cataract surgeon's point of view, your comment, sir.
Well, I think from a cataract surgeon's point of view, the only thing which Lalit told me the other day, which I'm not very sure, he says that the number of intravitreal injections has increased beyond the number of cataract surgeries that are being done every year in India. So I don't know what is the number of intravitreal injections if they are more.
Because the same patient we inject every month.
No, that is fine. That I agree. So that means that you are
Multiple.
close to, you are above 6.5 million, right? So,
That is true,
I
actually.
don't know. Sorry?
The number of injections has overtaken the number of cataract surgeries all across. Number of injections.
Yeah.
that is-
So that is,
Per patient will have
that
easily
is the
20
importance
injections.
of it.
12, some patients will have 12 injections, some will have 6 injections.
Whereas they'll have only 2 cataracts.
We are not
If I can make a point here, is the gene therapy where you can just give a single injection and it seems to work forever, actually. So that
Yes.
seems to be very promising. I don't know, Dr. Atul could speak something on that.
The economics don't work out because it's so expensive right now and still in the experimental phases.
Yeah, it is experimental, but it would be a one-time treatment.
The one-time treatment, but we have to see the future what it holds. But this we have a angiopoietin pathway which can be inhibited plus the anti-VEGF pathway, then we can maybe have better results. No scar.
Can I ask Dr. Atul a question, Dr. Partha?
Yes, sir. Yes, sir. Please.
Atul, what do you feel about the emerging role of therapy in dry AMD? Taking Malika's question forward and the role of gene therapy in it.
There's a lot of interest and work going on dry AMD in the US using gene therapy for dry AMD. So dry AMD visual loss is not so severe, but they're still going to treat dry AMD because there is a population which suffers from dry AMD. But usually I see it's a combination of neovascular dry. I don't see dry so often. It's the scarring which see. The neovascular is what is seen more often. I don't think dry AMD patients actually come to you only because they have a mild dysfunction. The fovea actually may not be involved only sometimes in dry AMD. So the neovascular AMD patients are the ones who are really upset and they're unhappy and their quality of life goes down.
Now, my point was that when we identify them at the outset with fovea not that badly involved with autofluorescence now, those are excellent candidates for preventing further visual loss.
Yes.
They have cataract surgery in conjunction later on.
Yes.
Can have an excellent, long-term prognosis if we have a therapy.
Absolutely.
The other one, fortunate we are, I think US has more geographical atrophy compared to India, because we did a study between Cleveland and Mumbai, and we found we don't see that many geographical atrophy, but they see a lot. And I think that way we are, I think, better off here in India.
I think we got a lot of polypoidal choroidal vasculopathy.
Yes. Yes.
Yeah. So, sir, I think from your very scholarly talk and a very practical talk also, all of us cataract surgeons do get the point that it is so important to actually not only very carefully see the fundus and the macula, but also do the imaging of the macula before the cataract surgery if there is any doubt of the macular involvement of any. Yes, Lalit, sir.
Yeah, you see,
Dr. Partha,
what Atul has done is that you see in 20 minutes, nobody on the earth can summarize AMD so well as Atul has done it. So congratulations, Atul, for this.
One question I have for Atul, sir.
Couple of points I would like to make is, because all cataract surgeons are hearing this. All cataract surgeons, before they do all this premium IOLs and all this toric and blah, blah, should always do an OCT first. I think he emphasized that.
100% we are doing it.
Always do an OCT first. Okay. First point is this.
No, but Lalit, why are
I'm just coming to
why premium IOL?
All IOLs.
Why only premium?
All IOLs. No, I agree. No, all IOLs. All cataract surgeons should have in their pre-op package. OCT is a must. Whether chargeable, not chargeable, you decide.
Agree.
Second point is, Atul will agree for this. Second point is that there is a lot of abuse of anti-VEGF which is happening. Atul, you will agree with this. We see every Tom, Dick and Harry keeps poking needle inside without understanding the disease per se. भाई 2 इंजेक्शन लगा दिया फिर भेज देंगे अतुल के पास, उसके बाद हेमंत के पास, whatever. You see, the understanding of the disease is a must before you poke needle inside. So there's a lot of abuse. Therefore, I have kept one talk, abuse of anti-VEGF agents. Third point is, which he also mentioned, is the newer drugs need not necessarily be better. You see, brolucimab in October, American Academy was launched, with a big fanfare. But occlusive vasculitis creates scare out of you. You see, because these patients, ARMD, if they become blind because of us occlusive vasculitis. You see, today, brolucimab is claimed to be a wonder drug. In US, people are shifting, but they have a scare in their mind. No, Atul?
Yes.
Because it's not, you see...
The intraocular inflammation is more.
Yeah,
4%.
apart from inflammation, occlusive vasculitis, I'm scared of. You see, if you ask me to inject, I will wait. So with these 2-3 points, and he very rightly said that faricimab first came for diabetic macular edema. And after showing great results in diabetic macular edema, now people are trying for ARMD also. And there are, phase 2-3 trials have begun for that.
Yes.
And we still have ray of hope. AMD patients still can see. That should be a message conveyed that the prognosis has improved for last couple of decades. No longer AMD patients, unless country is going to atrophy, but a huge number of AMD patients, we can improve the prognosis by careful following. And the way to go is treatment extent kind of regimen. I think that he also hinted.
Yes.
Thank you very much.
Atul sir, just from the anterior segment point of view or a cataract surgeon's point of view, two questions to you. You mentioned about a choroidal cleft. So what precaution would you like to tell the cataract surgeons in a case when you have a choroidal cleft due to repeated injections? Second question is, if you have a RP rip, how would you tell the cataract surgeon to manage his cataract, or what precaution to be taken in a patient with RP rip?
He's got a very high tense PD. The only option left, it's a very good question you asked. Either you can leave it alone, but fibrovascular PD, usually it is meant to be treated. But you have to tell the patient that there is a chance you've got a huge swelling on the retina. You'll have to talk in layman's terms, show the OCD to him, discuss it and counsel him that you got a huge bleb, and tell him the height is more than 500 microns. They'll understand. Tell them that this injection, which we'll give you before the cataract surgery, or otherwise also even after cataract surgery, can tear this bleb, because the vascular channel, the vessels shrink, and this tangential traction, the RP rips. So there is a very high risk of ripping, and they will have distorted vision. Though the anti-VEGFs may continue, but their vision becomes a little distorted. So we'll have to tell them that, because this is something still we don't have control of. To prevent RP rip, we don't have any control, the retina beam, because it can happen spontaneously. It can happen after anti-VEGF, but they say the incidence is more after anti-VEGF. So I think we'll have to discuss it with the patient that the RP, if the elevation is there, it may rip.
Any intraoperative precaution for a choroidal cleft because of repeated injections?
You can give an
cataract surgeon.
Give an anti-VEGF at least week, because anti-VEGF acts maximum on 10 to 14 days. So give it at least 10 to 14 days before. 2 weeks before you give the anti-VEGF.
Okay. Thank you, sir. Now we'll go to the next question.
1 minute. One important point which Atul highlighted, which I noted down, I forgot to tell, which I am enjoying using the OCT angiography. As you rightly said, the net is seen better than, we're not doing angiographies now. Very rarely we do ICG also. But I think OCT angiography has a role, but maybe many don't have it, but at present it is academic. But it's really great to see the effects of anti-VEGF and any anti-angiopoietin, and also to use in the OCT angio in the ARMD. I think it's a real excellent point. You didn't spend much time because of the time limitation, I think. But I think
because of paucity of time. Yeah. Thank you.
Sure.
Thank you, Natarajan sir. We'll go with the next case presentation now. We took almost 1 hour. Very good talk, Atul sir, and very great discussion. We still have 6 more cases to be discussed. So this is not the end of the webinar yet. So I would invite our scientific committee member to introduce our first speaker for this case presentation. So I would like to invite Dr. Somshila Murthy to introduce our first speaker.
Thank you very much, Amit. Very good evening to everyone.
The slide has gone off, Amit. Okay, fine.
So,
I will share that slide.
Somshila, you have the slide now?
I do
I
have
will
this.
share it for you. I will share it for you.
So I think with the very interesting first discussion that we had, let's move on to the next part of the session, which is case presentations. And it is my honor to introduce the first presenter for this evening, that is Dr. Vishal Agarwal. Dr. Agarwal is Associate Professor at Jaipur in SMS Medical College. He is very young. He's had 10 years experience as faculty and teacher, but despite his youth, he's an excellent clinician. He did his FRCS from Glasgow and ICO Clinical Sciences in 2010. He also did his post-graduation from RP Center in AIMS, New Delhi. and his Vitreoretinal Fellowship from Shankar Netralia. He has presented at various scientific meetings. You may have heard his presentations before. And he has co-authored several books in his subspecialty. And he has more than 20 peer-reviewed publications already, to his credit. And his forte is that he performs light surgeries at various national conferences. And he's also on the editorial board on IGO. So we look forward to the first presentation by Dr. Vishal Agarwal.
Welcome, Vishal.
Thank you, sir. Ma'am, can you stop? Yeah. Thank you, madam, for the kind introduction, and thank you. Can you see my slides, sir?
Yeah.
Yes, we can.
Yeah. Thank you, Dr. Partha, sir, and AIOS for having me here. So I'll be discussing the topic given to me, that is cataract and multiple PED. I'll be sharing my experience of two interesting cases in brief. So the case one was the patient was a 63-year-old gentleman, and he had bilateral cataract, nuclear sclerosis grade 1. The vision was fairly good. It was 6/12 in the right eye and 6/6 best corrected in the left eye, and the near vision was N6 best corrected. And he was referred to us for a fundus examination because there were multiple drusen's in both the eyes. The right eye had multiple drusenoid PEDs and had a old epiretinal membrane, and he knew that from a previous consultation also. And this was way back in 2017. This is the right eye of the patient, and this is the left eye, which I want to focus on. And this also had the similar picture without the ERM. The vision was around 6/6, 6/9 best corrected, and the patient had multiple drusenoid PEDs, large colloid PEDs in the posterior pole. And the patient was having the only complaint of slight metamorphopsia. Otherwise, he was able to read and see in distant very clearly. So we followed him. There was no fluid in any of the scans performed. So we followed him closely every 3 months. This was a June 2017 scan OCT of the left eye, showing the same picture with no fluid. And then he came in January 2018. The vision had deteriorated to 6/12 parts, and the cataract had progressed to nuclear sclerosis 2, and he was advised cataract surgery at that time. And before doing the surgery, we scanned him again carefully, and in every section we did FFA also, and there was no fluid in any scan. And this was the this is the video scan of the left eye OCT. So as there was no activity, the macula was dry, and the picture was the same as it was 2 years back, 1.5 years back. We went ahead with the uneventful phaco-IOL in the left eye. After 1 month of the phaco-IOL in February 2018, the patient presented to us, and now you can see closely the changes. To a cursory glance, it might seem that there is no change, but if you look closely, so the yellow arrowheads, indicate the fluid intraretinal, and the red arrowhead, show the hyperreflective dots which Dr. Atul was mentioning. And the green stars, is the activity in the previous pigment epithelial detachment, which was not there, with increased transmission. So there is an activity. There was a speck of hemorrhage at that point at the fovea, and the vision had dropped to 6/18 parts. The treatment was, of course, left eye intravitreal injection, ranibizumab 0.5 mg, 0.05 ml. 3 loading doses were given, and after that, PRN regimen was followed. The last follow-up, he responded very well, but then again there were recurrences, and this was the last follow-up before he dropped on the consultation, and there was still some fluid left, and he was advised injection, but he did not turn up. Case 2 is a 70-year-old female with bilateral cataract, nuclear sclerosis 1-2. The right eye vision was 6/6. The left eye vision was 6/9 parts, best corrected. Again, referred for fundus examination for drusen's in both the eyes, and the patient did not have any complaints, slight metamorphopsia, and this was the fundus picture in 2016, the first consultation in January 2016. As you can see, it's a mix of soft drusen's and some cuticular drusen's. And there is a speck of, scarred CNVM on the superior part of the fovea. But on the OCT, there was some, cuticular drusen's, some PEDs, but no activity. So this was a HD scan. So this is a screenshot because your macular cube video can be captured, but not a HD video. So that did not show any activity in any of the scans. Again, regular follow-up. So the patient was very particular about the follow-up, and there was just a slight metamorphosis in every follow-up, which was not increasing. The ampular monitoring was prompt, and there was no activity, and the vision was stable. 2017 scan still the same. So 2018 the vision slightly dropped, and there was a slow progressive diminution of vision, and the cataract surgery was planned as the cataract had progressed. And again, before the cataract surgery, the left eye cataract surgery was done, uneventful phaco. And before the cataract surgery, FFA was also done to, just rule out any possibility of any activity in the eye. And as you can see, there's just staining of the old lesions of the drusen and of the scarred CNVM, but no activity as such. Again, after 1.5 months, the patient came grudging, complaining, shouting, and the patient had drastically dropped because there was an activation of the CNVM. There was blood, and you can see the superior part of the fovea in between, at the edge of the scarred CNVM previously, there is a fresh bleed, and you can see the FFA, and there is activity on the angiogram, and this fluid, and there is activity. So left eye intravitreal injection ranibizumab 0.5 mg was injected, again 3 loading doses and PRN thereof. And the last follow-up, again there was activity. The patient responded very well, but then she dropped out because she was not being told how many injections would be given in the future. And this was the last follow-up when the patient dropped. So to summarize, in the start there were some studies like Beaver Dam and Blue Mountain studies which postulated progression of AMD in association with cataract surgery. But lately, all the studies, even the ARID study and all prospective studies also do not find any correlation between cataract surgery and AMD progression. So the common consensus is it does not. So cataract surgery is commonly performed in AMD patients, we all know that. And every cataract surgeon and retina specialist has seen patients that undergo cataract surgery. And these things happen in the post-op period. So mostly that is because of undetected lesions preoperatively, or because of the cataract is dense enough, so there is a suboptimal macular view and lack of high resolution imaging like good OCT or good OCT angiography or ICG. But if you remove that bias from the equation, there is a very low incidence rate of neovascular AMD development between 1 week in the first year of cataract surgery. And of course, a preoperative VR workup, proper consenting and prognostication is very important, especially in your premium IOL patients. So just to highlight, case 1 was a development of a new lesion with activity after cataract surgery. Case 2 was reactivation of a quiescent lesion. So the common denomination being that both these patients did not have any activity for a couple of years before the cataract surgery was performed, and immediately post-operatively 1.5 months, 2 months, they developed the activity. So that might be coincidental, but it's very difficult to convince the patient of the same. Thank you so much.
Thank you, Vishal, for an excellent presentation. And I think you are the opening batsman for this session with all the case presenters. And this is a very, very important aspect that every cataract surgeon comes on. We are dealing with the senile population. They have RP changes. They have the drusen. How seriously to take it? How seriously to take it? How to monitor? What investigations preoperatively and the follow-ups thereafter. Home AMSLR, anti-VEGF as and when required, and antioxidants, the roles. So here we have our three discussants, Professor Namrata Sharma, we have Dr. Rajiv Chaudhary and Dr. Hemant Murthy to discuss. Please.
Very well described by Vishal. It is a very common problem with the anterior segment surgeon having a small dry RMD, and many times it is neglected. So it has to be decided at what time to be operated if it is a cataract early, the cause of the vision loss because of the cataract or because of the AMD. And sometimes that patient didn't get operated and he feels that deterioration of vision is because of the cataract and there is an increase in AMD. So monitoring, if patient is not willing for surgery, it is to be advised AMSLR, and it is to be properly explained that he has two problems, not only cataract, he has an AMD also, which is an early stage. We may be dry or you have done the OCT and it needs follow-up for the AMD also, not only for the cataract. And same is with what explained that it can precipitate and it will blame the intersegment surgeon that surgery is the problem. So counseling is most important in this, that this cataract surgery is not going to deteriorate, but that AMD or that macula may deteriorate, and later on it has happened in the 1 month. It may happen after 4 to 6 months, and he come with that you are operated and it is because of this. So that requires proper counseling and proper follow-up also, and that Vishal has done very well.
Hemant Murthy, sir.
Yeah, Vishal, good representative cases you have shown. Some things that, the first case was primarily what we come across, a patient of dry AMD who had some PEDs, who developed, new lesion after surgery. On my part, I would probably like to do some other tests, like what Dr. Atul Kumar was mentioning about either doing an octa in those cases to find out whether there was the activity that we observed was primarily due to neovascularization or just a post-cataract, some fluid that occurs after cataract surgery. The second case is a known problem that we encounter, that is patients who are of previously known cases of AMD. We need to tell the patients that this lesion could reoccur anytime. It could be, in the natural course is just the same. For that patient, probably it was quiet for some time, but then recurrence is always known. So we always tell our patient, be ready for the recurrence. Cataract surgery is just one part of your,
Yes.
the course of events. It is unlikely that the cataract surgery is going to alter your problem. It is in the natural course. So you have to be ready for this recurrence and get it treated as and when it recurs.
So can I make a point here?
Yeah.
So I just purposefully took the cases 4 years back. At that time, we did not have a octa, and that condition, is reflecting on our anterior segment colleagues' OPD, in which a higher end machine like octa is not available generally. So they do, of course, most of them, of course, have a OCT. So OCT will not tell you the full problem, and they, of course, serially follow up the OCT scans. But that is the infrastructure they have. So if the point is, if such lesions are there in the preoperative fundus, you should get a serial follow-up with the VR surgeon. Just not look at the scans and see that there's no fluid and go for a cataract surgery. So that is the point we want to make here.
Correct.
Namrata ma'am, your views?
So Vishal, I have a question for you. Again, excellent cases. You are from our institute, and we are always proud of you. And it was excellent set of cases. I wanted to ask you just one question. Are there any studies to show that the dry ARMD will go into a wet ARMD? And again, this is from the cataract surgeon's perspective. Dry ARMD will go into a wet ARMD if you do cataract surgery. Is there some?
Yeah, so that I mentioned in my penultimate slide, madam. And in that, all the studies which related cataract surgery with progression of dry AMD were, in 99 or in the early 2000. Because at that time, I feel that they did not have the scanning modalities which we have today. And they used to miss the occult membranes which could not be seen by fundus examination and then prevalent OCT scans. But most of the studies in the last decade do not show any correlation of the progression.
And does dry ARMD have greater propensity for cystoid macular edema? And what if a PCR occurs? Do you think the occurrence of a complication would hasten the macular pathology?
Yeah, so intraocular inflammation, of course, can increase CME. So the bias of complicated surgery has been removed in this presentation. So if you have a complicated surgery, n number of things can go wrong. You can have cystoid macular edema without any pre-existing dry AMD also.
And would you have done a fluorescein angiography? I think Dr. Hemant Murthy also asked you the same thing. Would you have done
angiography was done in both the patients, but in 2016 we did not have the octa at that time. So presently I would have done an octa also to see any lesion which we are not seeing on an angiogram or a OCT.
Vishal,
Partha, I would just like to congratulate you. Never in a physical hall can you get so many retina surgeons and cataract surgeons together. Because cataract surgeons are running in their cataract halls.
They don't go along very well.
Yeah, retina surgeons in the retina hall, and you can never think of a session, like this in a physical hall.
Virtually together.
Thank you to you, and congratulations for getting, everybody together
Thank you.
on one
Thank you, ma'am. Thank you, man. Vishal, I had a question for you. Now, suppose the degree of cataract or severity of cataract is so high that you are not able to do an OCT of the patient. How are you going to counsel the patient if we don't know the fundus status? How are you going to counsel this patient? Number one. Number two,
yes.
second question. Is cataract surgery going to worsen, I mean, from dry AMD to wet AMD, if it is an uncomplicated cataract surgery?
Okay. So your question number one is, how would you counsel if there's no proper fundus view? So not just in AMD, in every case in which you think or you have a doubt that there is a fundus pathology, I always tell my anterior segment colleagues, okay, get a fundus examination done by a VR colleague, and even if he or she cannot see the fundus, then you just mention the words like preparatory, phaco, and guarded visual prognosis, and a proper consenting before the surgery to keep you safe, and a possibility of anti-VEGF injections or surgery, oblique surgery, in the post-operative period. That prepares the patient a little bit of the post-op outcome. Of course, sometimes if you frighten the patient a little more, the patient might drop off. But it's better than the mental trauma you face after the surgery, especially in premium IOLs. So whether it's diabetic retinopathy, whether it's AMD, just mention the words preparatory or anti-VEGF be required in post-op period and guarded vision.
I think Vishal, most of the cataract surgeons are well versed with the 90D. They do a 90D examination and they're not able to see the fundus clearly.
I would differ from that.
No, Vishal, 1 minute. Vishal, let me come to it. Let me finish it. Instead of a 90D, if we encourage our cataract surgeons that if you're not able to see the fundus with a 90D, use an IO. That will give a better clarity of the fundus.
Absolutely.
That is the ideal situation, but unfortunately,
that's the message I want to give to the cataract surgeon. That's the message I want to give the cataract surgeon, that 90D is not only into 20D is not only in the arbitrary of the VR surgeons. Even we cataract surgeons should start using it.
Exactly. Everybody should be well versed.
Second question, Vishal.
Doubt, refer to the retina surgeon there.
Yeah, that's true. Vishal, second question.
Second question was the same as Dr. Namrata Madam's question, that is there an evidence of progression? So right now, there are no studies correlating a progression of AMD with cataract surgery.
Okay. Thank you, Vishal. So we move to the next presentation.
One question. Rajiv sir, yes.
Is family's tree or other eye fundus will help?
Definitely, sir, because most of these cases...
Then we probably better assess that. And many times now, patients
if the cataract is dense enough, you can see the other eye if the cataract is, But the point is that you do not advise the surgery the next day and do it. Keep the patient for a follow-up for a couple of months, get a couple of VR consultations, and the patient is also then prepared and the surgeon is also prepared for the outcome.
Okay.
Dr. Mohan, you had a question?
Yeah, I had a question for Vishal. A lovely presentation, Vishal. I just want to know, the second case, there was a pre-operative fundus photograph, which I thought there was a small membrane there that probably became active. So this is what we have to keep in mind. When we have a cataract surgery done, when we have a subtle membrane, occult membrane, that could have become active post-operatively. This can occur.
Yes, sir, I mentioned that it was a scarred membrane, and pre-operatively an angiogram was also done which showed no activity. But these things can happen. The activity can be, so if it happens 1 year afterwards, the cataract surgery, then it's okay. But if it happens in the immediate post-op period, then the patient will be hell-bent on suing you. So that's the problem.
Thank you, Vishal. So
very nice.
We go ahead with our next presentation by Dr. Srinivas Joshi, and we have our scientific committee member, Dr. Jatindra Bhalla, to introduce our next speaker, Dr. Srinivas Joshi.
Yeah. Thank you, everyone.
Dr. Bhalla, your slide is not visible properly.
It's not visible?
No. I think you just stop sharing. I'll share the screen for everybody, for all the presenters, for all the introducers.
You can do that.
Yeah. So you just stop sharing it?
Yeah.
Yeah. So over to you, Dr. Bhalla.
Yeah. I'm not seeing the slides. Yeah. Thank you, everyone. And it's my privilege to introduce Dr. Srinivas Joshi, who's a renowned vitreoretinal surgeon from Hubli. He completed his MS ophthalmology from Belgaum, and then he received his elective training in VR from Charles Retina Institute, USA, and also completed his surgical fellowship in vitreoretina from University of Toronto. His areas of interest are artificial retina, the Argus 2. He is one of the first Indian to be trained in artificial retinal implantation surgery under Dr. Robert Devaney at Toronto Western Hospital. and he's recipient of Senior Honor Award by American Society of Retina Specialists, Boston 2017. He's been awarded many awards, and one of them is prestigious Red Buckler Oscar Award by American Society of Retina Specialists at Boston. And he's also been honored with the International Hero Award by All India Ophthalmic Society in 2019, peer reviewer of national and international journals, including AGO, Asia Pacific Journal of Ophthalmology, and Indian Journal of Ophthalmology. So over to you, Dr. Srinivas Joshi. Space is all yours.
Thank you, Dr. Balla. To add, Dr. Srinivas is an alumni from where I did my MBBS and ophthalmology. So it is Jain Medical College, Belgaum. Thank you, Srinivas. All to you.
Srinivas is mute. He needs to unmute.
I'm really sorry. So at the outset, I would like to thank entire AIOS team and especially Dr. Partha Biswas sir for this wonderful opportunity in this interesting webinar. And thanks Dr. Amit and Dr. Balla sir for the wonderful introduction. So without wasting much time, let's go on to our topic. It's multifocal IOL, as we all know, is often discouraged in patients with the retinal disorders, basically including diabetic retinopathy, age-related macular degeneration, or epiretinal membranes, because it is known to reduce the contrast sensitivity. So we have a recent paper done in July 2020 when Dr. Lalit Verma sir was telling the importance of OCT in all the patients who undergo cataract evaluation for multifocal IOL especially. And if you see here, that in this journal, it has been quoted that 20.5% of the patients undergoing cataract surgery may have macular pathology, of which 11% may not be detected in initial clinical examination. And it added telling that though OCT might be an extra cost, but definitely the detection of the macular pathologies and the improved quality adjusted life years over the time is much, much better. So let's go on to this case. 61-year-old software engineer, bilateral drusenoid PED, you can see here. And then he has a right eye multifocal IOL. Now what comes next? He has cataract in the other eye. So scenario one, which lens to consider? There's a plethora of lens, whether you want monofocal, multifocal, what to choose, how to choose. So there's another interesting study here. IOL selection for patients with age-related macular degeneration. The stage of the disease must be considered in choosing the best lens. So it states that the patient without any clinical evidence of macular disease, that is no drusen pigmentary changes, but still having a strong family history, are still considered normal patients, and direct counseling on the potential pitfalls of multifocal IOLs can be carried out. Patients with early maculopathy, like if they're having soft drusen or any pigmentary changes with relative sparing of Snellen acuity, then they are relative contraindication, not absolute contraindication. That is, they have a milder forms of AMD. Now coming to moderate or severe AMD, that is presence of large drusens, geographical atrophy, or exudative or the wet AMD changes, then definitely multifocal IOL would have a deleterious effects on the visual function. Monofocal and toric IOLs can be the other alternate benefits. Now coming to the situation, if the surgeon wants multifocal IOL, the patient also wants multifocal IOL. As we all know, having multifocals in both the eyes increase the depth perception and the stereoscopic view. So what are the pros? Better visual experience, reduced lifetime cost of the glasses, more freedom, and definitely when you have higher end technology like the multifocal or EDOF or TriDOF, whatever it is, then you can also use AI, which I'll be coming in the later slides. Now, what are the cons? Contrast sensitivity is reduced at higher spatial frequency, and some studies have shown that it reduces even in lower spatial frequencies. Night vision issues like halos, glare, starburst, sometimes it can be permanent. So if you look into this ocular surgery news, and which is done by Cynthia Matosian and Catherine Hatch, they have shown that many authors have shown that the patients who prefer multifocal IOL, or if the doctor puts multifocal IOL in the patients who are having retinal pathologies, they lose their independence and ability to read. Often they are no longer able to drive or to engage in activities they love doing. And several articles have listed depression as something that is very uncommon to the patients with AMD. Therefore, the patient says that no in cases of having any retinal pathology. Now, if you look into the demographics, some authors might argue. See here, if you look into the demographics, 60 to 64 years, they have only 0.4% of changes of AMD, wet AMD. Whereas in geographical atrophy, it is just 0.3. If you take 75 to 79, it's just 2.2%. So rest 97% are still fit for multifocal IOL, that the surgeons might argue. And if you look into the lifespan of Indian population, it is around 70 years. So if you go into this slide, so if you take approximately around 2.2% of the patients can convert to wet AMD, 1.8% of the patients going for geographic atrophy. That means still 95% of the patients is still left behind, and you can choose for multifocal IOL is what some surgeons might argue. Now, this is the slide which I took just now from the Atul sir's slide. See here, the global prevalence itself is 8.7%. So that means 92% are still considered fit for multifocal IOL. So what are the shortcomings? They have done a lot of studies and shown that combined phaco-vitrectomy, membrane peeling, and MFIOL improved with idiopathic ERM. So scenario 2, wet AMD or geographical atrophy. If it bleeds, then there is plethora of anti-VEGFs available. There is Amsler chart, technology to support the disease, home-based OCT, especially this is something very interesting called as nodal vision, AI-based nodal OCT analyzer. So if you have a high-end lens, then you can always afford for these home-based OCTs, which takes 10 OCTs per day. It sends a signal to your doctor, yes, I am having some changes. It alarms you. Then you can go back and see your doctor quickly. Last scenario, if there is a bleed at the macula, then what is the another most common debate going on? That the viewing might be uncomfortable for the vitreoretinal surgeon. So whether it's a biome versus the contact lens. So many of the authors have shown that diffractive multifocal intraocular lenses interferes with intraoperative view. They say that we could consider doing a macular surgery, but still there were wave-shaped arches may indicate how aberrations affect the intraoperative view. There is another author which says that you can put a helon on the surface of the multifocal, below the surface of the multifocal, and you can get away with the difficulties you see through the diffractive rings. And lastly, I would like to say this, comparing the effect of monofocal and multifocal, it said that only decentration of the multifocal causes problem in the VR surgeries, not the multifocal if it is sitting in a proper position. So I'll show you the last 20 seconds video I did just a few months back. This is a multifocal patient with a complicated retinal detachment. The patient had anterior PDR. So you can see there is a PCO here. This was the Panoptix lens. You can see the view is not bad. I could perform this surgery with the PDR. You can see I'm removing the membranes over the macula and even the subretinal gliotic at the periphery. So probably with 3D visualization, I might agree, or some might agree, that parfocalization actually happens on the surface of the retina, so that anything on the lens surface might get mitigated. So because of which the clear view might be there. So lastly, to conclude, this is a wonderful study recently done by Andrzej Gibrowski from Poland, and I was happy to be in the part of one of his instruction course. He says that we were unable to find evidence suggesting that patients with macular disease should be advised against multifocal IOL. Several contraindications for MIOLs with retinal disease have a hypothetical character and are not evidence-based. And more research is needed, especially to address the effect of MIOL, especially on contrast sensitivity, visual functions, and orientation, mobility, and etc. So with this, you have to choose whether you want a clarity or a convenience. If there is a clarity, then go for monofocal. Convenience, you can still go in for multifocal, but definitely with some risk factors involved in it. So with this, I would like to acknowledge the Department of Vitreoretina and Cataract and our two favorite fellows, Karthike and Giriraj, for helping me. Thank you very much. And this is the confused patient of the multifocal, which I'm showing. Thank you.
Thank you, Srinivas, for opening up the Pandora's box.
Yes.
With the myth which has always been said that multifocal is a big no in retinal pathologies. And now suddenly your presentation has changed the whole mindset. I don't know whether you're encouraging your multifocal, your cataract surgeons or your surgeons in MM Joshi to do more of cataract with multifocal. So to discuss this, we have our discussion, Srinivas. I'll come back to you with this.
Yeah.
We have Dr. Nishikant Borse, Dr. Lalit Verma, and Dr. Mohan Rajan. Dr. Mohan Rajan will talk about the cataract surgeon's point of view, and Dr. Nishikant and Dr. Borse would, I would like their opinion from what was suggested and what Srinivas is suggesting.
I want to pull up Srinivas.
Retina fellow,
I know, but now he's converted into a cataract surgeon.
I know.
So that's why I kept him.
And so happened, first cataract he did with me.
Absolutely.
Okay, so here what happens is when you put a multifocal lens, there are 3-4 points we should know. One is whether the patient already has a macular disease, the person is aware of it, and in spite of knowing that there is a macular disease, and you go ahead and put a multifocal without counseling the patient properly, he is going to be extremely disturbed, because his expectations are that whatever distortions were there due to the AMD are going to disappear with the panacea of a multifocal lens. So that is the first thing. So you have to really counsel the patient well, if at all you're going to put your foot into it and putting a multifocal. If there are undetected also, like, macular disease was undetected and the anterior segment surgeon went ahead and put it, and then in retrospect the patient is unhappy and the patient comes back to you, and then you find macular disorders, and then you tell that, yes, there is a problem. So these are the scenarios where the patient is extremely unhappy. But in my VR practice, I've seen there are certain scenarios where AMD patient is extremely happy for near vision, I should say, because of a multifocal. Because if they put a glass on top of a multifocal, they get a magnification which is not the same that you will get with a monofocal, and they are many times happy in certain circumstances for near vision, especially if they have the low add multifocals put in them, and they are that way happier. The only other thing I would say is that we do exchange multifocals many a times for patients in whom they are unhappy, and you take out the multifocal and then you put a monofocal. But I really don't remember doing it very often, just because the patient had an AMD, and if he has been counseled properly, what to expect, I think the only plus point would be a better near vision and a bit of independence. But yes, all this should be done with a caution in mind. What do you think, Dr. Mohan Rajan?
Yes, absolutely. You want me to comment?
Yeah, Dr. Mohan, your comment on this.
Absolutely. And let me thank Partha for the wonderful opportunity, and also Srinivas, compliment Srinivas for the very nice lucid talk, I would say. But I would tend to disagree with him in certain aspects. One is multifocals, definitely when you have a macular pathology, see what happens in multifocal is there's a decrease in the contrast sensitivity in the multifocal because there's multiple points of foci. Okay, so that's one important thing. You have to understand this very clearly before you tell the patient. In the presence of a ERM, you do a ERM removal, of course, you do a vitrectomy and then put. Exactly, problem is when you have a ERM, you will not be able to get the right power of the lens in a multifocal lens. Please understand. And you have to be bang on target on a multifocal lens. If you're this way, that way, you're screwed up completely in a multifocal lens. How do you get the correct power in IOL master when the ERM is there in the macula, in the fovea? You tell me. So it's not possible at all. So I don't think there's any question about having a multifocal in any macular pathology. The only indication for me, as Nishi was telling, is that I have patients, I have about 10 or 15 patients I have done, wherein above the age of 80, dry AMD, I've been following up for almost 10 years. Nothing happens to them. These are patients who want near vision only. So these patients, I put the thickness multifocal. I used to put restored multifocal +4, but nowadays restored multifocal +4 is not available. So I put a thickness multifocal +4 for these patients, which acts as a nice low vision aid for these patients. Because these people are not bothered about the distance at all. They want to read. So that actually is a very good point what Nishi mentioned. And I use it as a low vision aid. On top of that, if I want to give another +2 or 3, I can give that also because the patient feels comfortable over a multifocal lens. So these are the few points I want to, but otherwise it's a really fantastic talk, Srinivas. Really, hats off.
Dr. Ali, sir, your views?
Take a comment, Amit.
Srinivas, thank you for creating all this confusion actually.
Let me admit today that I was told to confuse.
So you see, tell me who is bothered about contrast sensitivity in patients who have ARMD? You see, vision ही नहीं है, ARMD आप contrast sensitivity का क्या बात? So contrast sensitivity is a very high, function. Snellen visual acuity होगा तभी तो contrast sensitivity की बात करेंगे. So don't, start your talk. Mohan also said contrast sensitivity is reduced.
No. I'm not trying to say contrast. Please understand that patients who have got.
Let me finish. 1 minute. I'll take only 30 seconds. So what I was saying was,
yes.
You see, retina surgeons most of the time, believe me, do not have any issues if they are performing VR surgery with the multifocal. Slight tilt here and there, sometimes but major, I haven't faced any issue that I'm operating a VR or a ERM surgery or whatever, RD, GRT, multifocal, minor additional problem. That's all. No major issues. So don't worry about the VR surgery being affected, Srinivas. That is out. And regarding choice of IOL, believe me, I leave it to the cataract surgeon. You want multifocal, patient wants, I am not going to come in between. Go ahead. But believe me, multifocals are generally, if you counsel well, if you counsel honestly, are not the preferred IOLs, even for people, without the ARMD also.
So can I just make just one comment? Can I make, sir?
Yeah, Dr.
Yeah. It is there was a publication by Joshua et al. In JCRS 2017 where they said that the CME after if routine cataract surgery was 1 to 2%, if you have combined surgery with ERM removal, the incidence increases to as high as 7%.
Absolutely.
Oh, definitely. You're touching the retina, so it's going to go high.
Yeah, if macular edema is increases, I think that is going to worsen his maculopathy. And secondly, the choice of IOL, do we advise the blue blocking IOLs because the normal IOLs may increase the macular damage? So do we advocate the
I don't think so.
IOL like
of
at all?
See, choice of IOL will be dictated by either Amit Porwal or Partha Biswas. Retina surgeon will not tell you about the choice of IOL. Believe me. Absolutely. I think Nishikant agrees with that. Multifocal IOL, I have no issue, provided you don't create PCR, provided IOL does not get tilted. That is where multifocal IOL.
Okay, let's take the question, Lalit sir, to the cataract surgeons. As you told, we leave it to the cataract surgeons. So we have Dr. Rajiv Chaudhary, Dr. Mohan Rajan, Dr. Ajay. I would like to ask you. The question was.
Yes.
The Srinivas's topic, what I remember was. One eye multifocal, both eye ARMD. Now other eye, should we go with a multifocal or a monofocal? Over to you, Dr. Ajay. I'm very specific in my questions.
Amit, can I ask, is the patient happy with the right eye or not? If the patient is happy with the multifocal of the right eye with ARMD, go ahead and do other eye if the symmetrical picture is there. If
symmetrical picture is there.
If patient has to be happy with the multifocal of one eye.
Now, what type of ARMD is important?
Yeah, that's right.
Very good.
Dr. Lalita just now pointed out, what time, when you said the AMD, is it a dry AMD? Is it an early RP defect, a few drusen?
Mild, moderate or severe?
Definitely a +4 in other eye, as Dr. Mohan has said, that a +4 diopter, which you can see better near vision, which got a contrast. But otherwise, if the patient is in a late stage, if has got a big scar or vision is 612 or 6, I would prefer a aspheric with a myopic shift, and maybe a bit of keep it an aspheric with -1 or -2. We'll get a bit of better near vision.
You won't prefer a multifocal which should act like a low vision aid, as Dr. Nishikant said.
Yeah, that's if it is a 612 or 6 or a N8 or N12 on the pinhole in that eye, definitely that would be a better choice.
But still, you would prefer a monofocal in case of an
aspheric. Otherwise, in a AMD patient, I'd always go.
Can you have a quick survey from all the cataract?
Yeah, from all the panelists. The question to all the panelists: multifocal or monofocal should be the answer. The question is one eye multifocal, both eye ARMD. Now ARMD moderate degree.
I will still prefer monofocal in the other eye with the slight myopic check. So you have the balance. Either patient is happy or not happy, because AMD may deteriorate later on.
Okay.
So if you have the one eye, if he is happy, it will work for near also. And other eye slightly myopic check. So if there is a deterioration, it will help in the long run.
Okay, Dr. Krishna Prasad.
Yeah.
What is your view?
No, let's just have a vote. I think Amit.
Yeah. Just multifocal or monofocal, Krishna Prasad.
I would like to go once again with the
multifocal or monofocal. Just multifocal or monofocal, one or two.
Monofocal.
Thank you. Thank you. Dr. Sonu, are you there? Multifocal, monofocal?
Monofocal.
Monofocal.
No.
Okay.
See, please understand, Amit.
No. The question is multifocal or mono. We discussed.
No, Amit,
We have to go to the next question. Next case.
You're talking about this particular patient. No.
I'm talking about one eye multifocal. Both eye moderate degree RMD.
One eye has already got multifocal. Why don't we put multifocal +4 in the other eye as well?
Yeah,
What is wrong with that?
Exactly.
You want to go for that? Okay.
Yes.
Okay. What about Partha? You are both combined anterior and posterior segment surgeon, but
I will go with my friend Mohan.
You're always with me, boss.
Okay. So, how many of y'all have explanted multifocal lens because of macular pathology? Has anyone in the panel, the senior ophthalmologist, the so-called high volume cataract surgeon, what was your indication for explantation? Patient unhappiness? Fine. So after experiencing this, would you still advocate a multifocal?
But we have even explanted it in people with not a macular pathology, mind you.
Absolutely.
So, I really cannot put my
this
point
webinar
on
is
that.
only on ARMD. So I would put up this question, that if you have explanted a IOL because of a macular pathology, would you still go with the multifocal in your future patients? Because
that's why
explanting
I'm
a
answering you.
multifocal after 1 or 2 years is not easy. Explanting an IOL.
If I have explanted 10 IOLs till today, I would tell you at least 6 of them were people with not a macular pathology.
Macular pathology.
I mean,
So multifocal
without the macular
dissatisfaction.
pathology.
Multifocal dissatisfaction. Okay. What about you, Dr. Rajiv Chaudhary?
I will not explant once it is there, because we are not able to, how much we will satisfy to the patient, because after removing, because AMD is going to be there, he will always be unhappy. So
okay, Amit, I think the last word is from Srinivas. The last word is from Srinivas here, and then we switch over.
Because he had the first word also.
Give the mic to Amit sir. It's difficult to close it, so I will close it. I have all the privilege. Thank you, Amit sir and Partha sir. So the first question, which Rajiv sir said, it's the blended vision concept. I agree with him that multifocal in one eye, with monofocal in other eye, that the patient will get the best subject. Right? That is what is all about. I'm here not talking about the patients who are already having macular pathology like ERM, macular hole or anything. The topic given to me was just a drusenoid PEDs and the conversion of the drusenoid PEDs to wet AMD and geographical atrophy. I have already shown it very clearly. Coming to the question by Bhalla sir regarding the blue blocker. Blue blocker cuts only 20% of the UV rays according to the studies, and which have shown that the 53-year-old crystalline lens will give as much as 20% cut which the blue blocker gives. So it's not advisable to have blue blockers in these kind of patients. Whether you want accommodating IOLs or the multifocal IOLs, you definitely have to do a wonderful counseling with the patient, sit with them, tell them the consequence that you might require further intervention forward. So at present, if you want multifocality, good stereoscopic, I will give you a multifocal IOL, but at considered guarded prognosis. If you are still willing with that, we can go ahead. Otherwise, I would rather like to conclude telling that monofocal works best when you have multifocal in one eye and monofocal in other eye. But my friend Andres Gibrovsky's paper, if you just go into that, he has screened 247 unique articles on multifocals with retinal disorders. There are only 2 special articles like Kamath et al. And another one. It says that nobody knows exactly in what percentage of the patient is multifocal still contraindicated in the initial form of retinal disease. So with this,
thank you, Srinivas. Thank you, Srinivas. You still didn't give a blanket statement to all the cataract surgeons. Multifocal dalne ke liye, there are still some reservations. Thank you, Srinivas. Now we go for the next case presentation. Thank you all discussants. I invite Dr. Krishna Prasad Kudlu, a scientific committee member, a dynamic scientific committee member, to introduce our next presenter, Dr. Parth Rana.
Thank you, Amit. In fact, it's my privilege to introduce the young dynamic surgeon from Ahmedabad, who's been working as both retina and ocular trauma surgeon in Nethralaya Super Speciality Eye Hospital. In fact, he is the son of one of the person who has made the Ophthalmological Society in Ahmedabad taken into a different level, none other than Dr. Rana. So in his young age, I think I've been keep seeing in a lot of medias nowadays, but the most important in this young young age only, he could able to patent few of the equipment, mainly Rana and Shah's self-sustaining serial tuck IOL. Probably it is designed to fix on the sclera without any need of any suture or glue or groove. Of course, we indeed very happy to be him here. I think his case presentation will be, I'm seeing and waiting which sort of case he's going to present. Over to Dr. Partha.
Thank you so much, sir, for this kind introduction. So here I am sharing my presentation. I have a kind of straightforward presentation with cases. I'm not going to quote so many of the studies here. So we are going with our first case. Like, it was a 58-year-old male, DV from past few months in left eye. He was diabetic and hypertensive from past 5 years. There was a NS2CO in left eye, and the vision was, there was a left eye vision. The vision was 612. And there was a tiny hemorrhage was there just beside the fovea. And we advised the patient for OCT, and the OCT showed a PD like this. And we asked patient for anti-VEGF, and we asked patient to wait for some time, then go for cataract surgery. But patient was like, no, I should go by myself. He just went to another doctor, and he just got operated there, and there was a breakthrough bleeding there, and the PED increased, and patient came to me after a month. The hemorrhage was partly dissolved there. They injected one anti-VEGF there, and then we started anti-VEGFs at our clinic also. And the case 2, there was a 62-year-old male DV from past few months in both eyes, non-diabetic and hypertensive from past 7 years. There was NS3. OS vision was 624 part. As we can see here, there was a CNVM there, and there's a large PED. We stopped the patient there for cataract, but patient went ahead, and patient came with this after a month. So maybe related or not related, but we found the case like this. And then we started the treatment with anti-VEGF, and patient was really angry with the cataract surgeon. Even though patient knew that he had a pathology in his eye, he was angry with the cataract surgeon that he did some mischief there. And there's a case 3, there's a 60-year-old male, and the DV from past few months in left eye, diabetic from past 6 years, and hypertensive from past 5 years. There's an NS3 VSE, and vision was around 612. And as we can see here, there was a tiny retinal arterial macroaneurysm there. We explained to the patient, and with the ERM was also there. With explained prognosis, patient went for the surgery, and post-op there was a sub-ILM hemorrhage. It was pre-retinal, and there's a breakthrough bleeding, and it was related or not related to the cataract surgery. But in a nutshell, in COVID times, most of the general ophthalmologists are avoiding fundus examination, but thorough fundus examination is mandatory before any cataract surgery. We can use non-magnetic fundus cameras or ultra-wide field fundus imaging systems. There's a proper informed consent is always necessary. And with consent, we have to even explain patient properly, and we have to take the patient's trust before going for any kind of surgery. And any eventful circumstances, we have to support our colleagues, because so many times, like when patients are angry, like we can see in social media and print media, most of the times what is happening, like we are not supporting our colleagues at some point, and then this thing happens. So when sometimes we see it can from far, it can be like this, but when we see from near, it can be like this. So in current times, before saving the world, we have to save our hands from burning first, and always consult a retina colleague in case of any doubt. It can share responsibilities, and there can be better outcomes. And always prefer macular OCTs before cataract surgery. I'll conclude my presentation here, because so many of points which I wanted to discuss have already been discussed in previous presentations. So thank you, Partha Bishwas sir and AIOS committee.
Thank you, Parth. Wonderful 3 cases you have presented. We have our discussants, Dr. Malika Goel and Dr. Mohan Rajan. Dr. Malika, over to you.
Yeah, good case series. I'm just wondering, looking at them, what was the vision? We don't have the visual acuity data on these patients. So was the vision reduced? Number one. Number two, the fundus pictures are so clear that it looks as if there was no cataract. So if the vision was poor, then it was obviously not from the cataract. The cataract surgeon should have understood that there is something else. Then if you see the OCT, especially in the second and third case, they're pretty deadly. The second one is obviously PCV, and the third one also is showing a lot of changes. So I just want to know why the cataract surgeon would have proceeded with the cataract surgery when the media was so clear and when the OCT was so also diagnostic. And what was the visual acuity change pre and post operatively? Is what I would like to know.
Pre-operatively, I have written here. Post-operatively, it was around 660 or less than that. And another thing, like this OCTs, if you can see there, like there was a little bit of signal loss there. And in this kind of cases, like patient came through another cataract surgeon and patient went to another cataract surgeon because we did stop them for cataract surgery and we asked them to go for anti-VEGF when patient didn't wanted to spend anything for anti-VEGFs. So patient went to another cataract surgeon, some trust or somewhere where they are not doing much of the investigation for fundus. And after that, this thing happened. And this 3 patients I chose because 3 of them were asking like this was due to like some mischief has happened in cataract surgery and it's just due to that. So we have to ask patients, we have to show them the OCTs pre or post-op, and this is just due to the progression of the disease, nothing because of the cataract surgery. They just wanted to sue the doctor, or they just wanted to just make a scene there, and we had to stop them. And most of the cases were happened in this trust hospitals nearby. So that's why I showed this cases.
So in these cases, you had already seen the patients pre-operatively. That's how you have the pre-op OCT.
Yes, ma'am.
So you had already advised retinal treatment and they had refused already.
Definitely,
So
ma'am.
there is no question of suing the cataract surgeon because you have already told them and they have refused treatment.
Yeah, because some private surgeons sent this to me. I just advised them anti-VEGFs. They went to some trust hospitals and they got operated. And if you can understand, and what they do in trust hospitals.
No, so I understand, but the question of patient feeling that there has been some mischief doesn't arise because you have already told them that there is another problem.
Very true.
No, we do not know what the counseling has been done by the cataract surgeon. That is the problem. No, he doesn't know what's happening in the cataract surgeon. The cataract surgeon would have promised good vision. Yes. Unfortunately,
the patient has already contacted Dr. Rana, and he has already been told that there is a problem which will not improve his vision. The cataract surgery will not improve his vision. He has been told. Now, if he takes that decision, then cataract was also there. He cannot blame the cataract surgeon. Okay, second point which I want to make is when we are counseling such patients, our language needs to be little blunt. When patients are able to get violent or hostile or aggressive, we also, on the defense, when we are seeing such patients, we should tell them, cataract surgery कराए तो vision नहीं आता, चला जाता. This is the word we have to say. If we try to be diplomatic and say, no, there is something at the back and we don't know what will happen afterwards, they forget all that. We have to say very bluntly that you will not get vision, you will lose vision, you will lose vision. When you say such words, that sticks to their mind and they will not go ahead with the cataract surgery. So we need to be blunt because they are also very aggressive when the results are not good. So we need to be blunt proactively, preemptively, not afterwards.
Yeah,
so
very true, Malika. You've really scored that point very well. Yes, Ajay, you wanted to say something.
No, I just wanted to say, as a cataract surgeon, I mean, this patient went off, that's different. Now you have a fluid and you're given injection 1 or 2 injections, you still have fluid. When you do advise a cataract surgeon, would you want it to get totally dry before it takes for cataract surgery? Or in between the injections, say maybe 3rd or 4th injection, you still advise a cataract surgery? I mean, I normally do it this way. I mean, I keep the retina surgeon in conjunction. He gives an advising twice or thrice. Patient knows that the vision now is due to the cataract. But as a retina surgeon, would you advise that the whole fluid dries off either it is a PCB or early PCB or even a simple CNV.
Yes, of course, the macular condition should be stable before you operate.
Absolutely.
Yes.
Definitely, sir.
Macular condition should be stable.
And by stability, what
Can
do
I
you mean?
can I make
Yeah, it
Don't
should be
be
dry.
a
It should be
persistent
dry.
fluid somewhere even after 3, 4, 5 injections, where the cataract keeps on increasing. So do you do it, advise a cataract surgeon to do it and then come back, let me continue?
Sir, in that kind of cases, like we found some of the cases like that, what we have tried, we have given an anti-VEGF with a tricot, and we have waited for a week or 10 days and then asked the cataract surgeon to operate and then come back again. We always explain them that cataract surgery is just a part of your treatment. Most of the treatment we are going to do it here. So don't forget after cataract surgery that you don't have to come here. There can be any complications. We explain them, proper consents are taken, patient has taken, proper trust has been taken, then we are asking patients to do like that. So that is the protocol we are doing, and we are trying a study also for that. So what kind of cases we are getting?
I think, it brings home a very important point is even if it is a speck of hemorrhage at the macula, it has not to be taken lightly.
Very true.
Total imaging has to be done, a confirmed diagnosis has to be taken, and then to proceed with the conjunction, as Ajay very rightly said, with the conjunction of the retinologist. The retinologist should give a go-ahead. If a treatment is to be instituted, institute the treatment, let it stabilize, and then do the cataract surgery, telling the prognosis to the patient that it is not going to be 6/6 or whatever is the expectation. The expectation has to be realistic. I think an excellent case, Parth.
Can I make 2 points? Just 2 points, Partha.
Yes, sir. Yes.
No. A very nice presentation by Patrana. I just want to make 2 points. One is 100%. Lalit Verma was talking about in the beginning of the lecture whether all the anterior segments surgeons should do the OCT for all not only premium IOLs, for all cataracts. Preoperatively, OCT is a must. You can do it even without dilatation of the pupil. The OCT is a must for all patients. Whether it's a premium IOL or a toric lens or a regular monofocal lens, it doesn't matter at all. So you need to know exactly what is the status of the macula. Second thing is, many patients, as you rightly said, don't dilate now because of the COVID era. They don't want the patients to wait for long. But I think it's important to dilate, especially when you're doing the cataract surgery, for 2 reasons. One, I should know how much of dilatation is occurring for this particular patient before I venture into cataract surgery. Number 2 is, I want to examine the retina, not only the macula, but also the retinal periphery. Please understand this also. I think it's 2 important points. Rana has beautifully mentioned in this. It's an eye-opener talk.
One point, if we are hesitant to do contact this 78D or 90D exam, an indirect would be very easy after dilating. You don't have to go very close to the patient in the COVID times. Indirect is much more safe and faster.
Absolutely.
Can I make one
And
point?
even in the slit lamp, Malika, even in the slit lamp, you have a shield and you're going away, and that's why I put it. That's why in the beginning of my.
But Dr. Natarajan, I find it very difficult nowadays with the patient wearing a mask. There is a lot of fogging which happens. With the indirect, it doesn't happen so much because the lens is little further from the patient's nose.
So I have now requested every patient to have a sticker for some time. As soon as they come near my OPD, I tell them put a sticker. Like I am putting a sticker, you also put a sticker for some time. Go outside and remove. And for surgery, I make it mandatory. They tell me it's all this thing, I'm not used to it. I said, it doesn't matter. Half an hour you practice before surgery, they have a gap, then I put it and come back at it. Because now I'm operating daily and I tell them this is what. So I think we have to train the patient. It is like, that's why I written this in the notes. That whatever cataract is blocking, that much will improve. And whatever, it's like milk and water together. You don't have a lactometer here to say how much you will improve after cataract. So I think the highlights, what you discussed on Partha's case were really relevant, where I think the patient should know, and counseling is very, very important.
Indirect for the periphery.
I just wanted to make to what Mohan Rajan sir said regarding doing OCT in all cases of cataract surgery. I think Malika madam will agree with me that most of the retinal surgeons, if you do it proper examination with 78D and 98D, with a good clinical acumen, we can still pick up most of these pathologies. I do agree that if it is a drusen, then you can definitely go in. But if there is nothing, then actually it is subjective. Some surgeons prefer to do it, some may not prefer to do it. It's not compulsion that we have to make it in all cataract surgeries. And secondly, when the changes already happen, that is the morphological changes, what we have to look in for is the biomarkers. What kind of biomarkers? Like say, for example, SNPs, complement factor H. These are the molecular biomarkers which tell that in future, this patient is going for AMD. Actually, that will change the way what we are looking at the retinal diseases now. But what we are looking into the OCT is when we already have a lesion. So what is required in these cataract surgeries, whether this patient is going for that so that we can choose whether it's a monofocal, multifocal, accommodative, trade-off, end-off, all those things. So this is just my point and suggestion.
No, very dense cataracts, very difficult to see the macula. You'll not be able to see the macula.
Yes.
We have found out in our study, in about 25 to 30% of the cases, we are able to pick up in cataract surgeries in preoperative evaluation, as high as 25 to 30% subtle changes like ERM, which has been missed by an indirect ophthalmoscopy or a 70 diopter or 90 diopter. So I think
it also
is a must.
Yeah, it also helps you to have a documentation that, you know, the macula was okay.
Yes.
Because many a times I've seen a patient has developed macular hole maybe after 4 to 5 months, and then the patient has blamed the cataract surgeon. And if there is a documentation that your OCT was normal preoperatively, you know, you can actually say that it is that way. So, you know, VMT, we cannot pick up VMT very easily.
Absolutely.
Many a times. So I think OCT in every patient is important. And maybe you can go in for a cataract surgery earlier only if the cataract is preventing us from sort of monitoring the macular degeneration that is going on. And then in only that case, maybe anti-VEGFs, we can go in for a cataract surgery earlier.
I think, Partha, as a scientific committee, you should bring out something like the AO preferred practice pattern as a guideline to the doctor, because otherwise already there is a patient complaints, you are doing OCT. I think Lalit put it in a different way, whether you charge or no charge, but I think you machine costs, and then second patient should know we are doing it for their benefit and not for making money. We are doing an OCT. So I think we have to put a rule where it shows that we are interested in the health of the patient and our aging patient, and I think that's why we are saying it's recommended to do OCT. And they should not take it as that, because when people are doing OCT, so many times patients say, how you are, I think, charging every time for OCT. So I think he said it, include in the package. Maybe there has to be a cost, and cost accounting is important because the patient should know the machine is not coming free, no?
Absolutely.
And at the same time, I think we are helping a patient.
Right.
Superb thought, Dr. Natarajan.
Thank you very
Dr.
much,
Partha, we have a work to do now.
Yes. Yeah. No. You have enough work to do. So that we can
one more work to do, Ed. One more work.
No, we have to safeguard our prestige as an eye doctor, because when somebody is advising OCT, now I don't know whether it is mandatory even in my hospital. I'm not sure. Because in spite of we have 4 retina surgeons, whether we are doing OCT for every cataract, I don't think so. Because I think it was a lesson to me today, but I don't know whether to, still I am thinking whether to advise every patient. Maybe AIOS should give a guideline thinking, and I think like ICU also has a thing called position report, they call it, where 8 experts from various parts of the India we should have, and make a document and publish it. And now we have IJO, you publish it and then give it to every person as this thing. So I have no prints now. Send as an document to every patient. That this is what our All India Ophthalmic Society has got a peer-reviewed publication.
Things like
OCT.
Absolutely.
Fantastic.
Yes, very true.
Like
One point, sir.
the OCT can pick up unless you.
The patients with the normal macula, and only few patients with the VMT will not agree to it, Mohan. When the patient is happy, even sometimes VMT you have 6/9, some patients are happy, some patients with 6/6, they're not happy.
The advantage of OCT is the pre-operative documentation is very important.
No, I agree. What I'm saying, when you do daily, but one surgeon is not doing it.
Now. You need to have documentation.
Correct. No, I agree. What I'm saying, if the AIOS scientific committee gives the homework as a document, if somebody is doing and somebody is not doing, and I think the doctor who's doing it will be protected, saying that he's doing not only for academic, he's actually doing for the good of the patient.
Yeah.
Thank you, Dr. Natarajan, for a wonderful suggestion.
And the not doing surgeon might get sued also, sir.
Yes. That will be a problem also.
We need to use a very dictated, proper language.
We have to be scientific. I think.
That is why I said you have 8 experts, and you have a person like either Deshpande or Nirmal Frederick in one of the committee members, so that when they advise, the word has to be recommended, not must.
Absolutely.
Advisable.
Yes.
Let us go to our next presenter, and it's none other than Dr. Manish Bashbach, and we'll have Dr. Sonu Goel to introduce Manish. Sonu?
Dr. Sonu, are you there?
Somshila
Sonu,
can
I
be.
think. Yeah, Somshila will go. Somshila?
Yeah, I'm here.
Yeah, can I put up the slide? Can you just introduce Dr. Manish?
Yes, good evening once again. Been listening to a very rocking discussion going on and a lot of controversial, perhaps important points. And I just enjoyed the discussion and great presentation so far. So coming to the next case by Dr. Manish Bashbach. So Dr. Bashbach is a graduate from Kasturba, Bapai, I'm so sorry, is from Kasturba Medical College, Manipal, and he did his DNB and fellowship from Shankar Nethralaya. And he was also awarded the Best Outgoing Student Award from DNB. So we have a lot of luminaries and achievers here amongst our presenters. He did his observership in uveitis with Dr. JB at Shankar Nethralaya, and also he did multiple surgical advanced courses, both at the European Vitreoretinal Training in Germany. He also did a postgraduate certification in business management at the prestigious XLRI in Jamshedpur. So he manages at his center, the vitreoretinal, uvea, neuro-ophthalmology, as well as trauma, LASIK, and cataract. So practically most of it. And the most important part that I felt was extremely interesting to know is that he has invented something called the claw. So the claw is not some monstrous thing, but it's a novel foreign body removal forceps, which was used extensively during the riots in 2016 in Kashmir, and this was used to remove the non-magnetic pellets from the eye. So it's very intriguing to read about that. And also his another innovation has received the All India S. Natarajan Award last year. So I welcome Dr. Manish Bashbach to give his case presentation.
Thank you, Dr. Somshila. I think Dr. Manish's innovation was presented in AIOS Indore. So it's a proud moment for myself and Dr. Rajiv Chaudhary.
And he also won the Think Under
Award.
the Apple Tree Award.
Yeah, he won the Think Under the Apple Tree.
Manish.
Very innovative guy.
Yeah.
Good evening, everybody. Thank you for a kind introduction. I hope everybody can see my slides and hear me well.
Yes.
So at the outset, I would like to thank AIOS Scientific Committee and Dr. Partha Biswas for giving me this opportunity. My job is relatively easier because I'll be talking about large hemorrhage at the macula in patients who are undergoing cataract surgery. So I'll start with few cases. The first case is a 67-year-old male patient who came with history of sudden loss of vision of few days duration, and this was his fundus picture. He had a large submacular hemorrhage under the macula, and he underwent TPA with Avastin and C3-F8 gas in the vitreous cavity. And after 2 or 3 injections, this was his fundus picture, and his OCT looks very good. There is only a small pocket of fluid under the fovea. The patient had good visual acuity. Here we can see that the media is little hazy because of cataract, and the proper fundus examination instead of directly going for cataract surgery helped in diagnosis. The second patient was a very interesting case. This is a very old case. This was prior to I acquired my OCT or started doing anti-VEGF in 2006. She had she had very poor vision, hand movements, and the other eye fundus was normal at the point of presentation. On slit lamp, she had very dense cataract, and here we can see that the cataract, there was some lesion which was there at the macula, which was fairly large, and in the ultrasound associated, we can see that there is a elevated lesion at the macula. So we explained guarded prognosis to this patient, and the patient underwent uneventful phacoemulsification with clear understanding that the vision will not improve and she will have central scotoma. 1 month post-operatively, she was treated with IVTA, and this was her, the picture on the right is her final picture. She still had 1 meter vision post-operatively, 1.5 meters post-operatively, and as expected, the visual prognosis was not very good, but we could tell her that because of the ultrasound in this particular case. The third patient was advised cataract surgery elsewhere and had come for second opinion. He had poor vision in the left eye, but right eye had good vision. It was 6/9 parts. He had cataractous changes, early cataractous changes in both eyes, but there was a large macular hemorrhage. As we can see, there is a macular hemorrhage which is there in all the retinal layers. The differential diagnosis was macroaneurysm. Here we can see a lesion and or IPCV. He was advised again intravitreal injection of TPA with TPA with Avastin and gas, but the patient refused because of economical problems, and he instead opted for anti-VEGF monotherapy. This was how the picture evolved over a period of 3 injections, and then looking at the retrospectively, it looks more like a macroaneurysm. Here we can see a macular vein being blocked, and there is a lesion on top of that, and the picture really improved. So it is not only AMD which can present with large macular hemorrhage. There can be other pathologies which can also present. We have to keep that in mind. This was another young male. He did not have any cataract, but he had aplastic anemia, and we can see these large Roth spots and subhyaloid hemorrhages in various places. And just with systemic therapy over a period of 3 to 4 months, his clinical picture improved, and he had very small macular hemorrhage. His visual acuity also improved quite well. This on the left is the picture of peripapillary CNVM with macular hemorrhage, while on the right there is a Valsalva retinopathy. Again, these are large macular hemorrhages. They are not necessarily AMD. They can be present in other pathologies. So other pathologies can also present with large macular hemorrhage, and we have to keep that in mind as well. So this was a high myopic patient who was prior to injection. Here we can see directly under microscope, we can appreciate large macular hemorrhage as can be seen. And so if you're taking a high myopic patient for a cataract surgery without looking at his fundus, you see this, it's going to scare you because it's not the cataract which is blocking his vision. Another very important fact is nowadays we see the biometers, optical biometers like IL Master 700 come with SSOCT, and they give us a picture of macula which is there in their one of the frames. And a surgeon, cataract surgeon, even if he is not doing OCT as we have been discussing throughout this webinar, even if he is not doing his OCT regularly, this is something that he needs to look at very carefully. So this is on the left extreme is the normal picture, normal macula that he should be seeing, while the other 3 are pathologies like macular hole, or there is a PD, or there is a pocket of fluid. So if you see this, at least if you see this, please then dilate the patient, look at his macula, and do OCT directly before taking the cataract taking him up for cataract surgery. This is a patient with large retinal hemorrhage, and the point that I want to make is if you're doing cataract surgery in these patients, you do not have any red reflex in case of large hemorrhages on the retina. Here, while doing rexis, even while cracking the nucleus or removing the last piece, we have no red reflex there. And in such a case, you are likely to catch the capsule and have dehiscence. So if you are, this is a combined case where we can see there is a large retinal hemorrhage in case of a PDR. So this was all was anticipated, but then if you are not seeing a red reflex after intraoperatively, there is something wrong going on there, and it's not plain cataract surgery. So coming to cataract surgery in AMD patient, most of the things have been discussed. So whether some of the thought processes are that probably there are increase in inflammatory markers like VEGF and exposure to UV light, which causes progression of AMD. Whether it is true, it's a very controversial topic. Mostly not, but then there is probably higher incidence of post-op CME in these patients. So how do we cover these patients who are having AMD, who are undergoing cataract surgery? We have to cover them with topical steroids in perioperative period, or probably for a slightly longer period of time, because they are likely to have post-op CME, if not progression of their AMD directly. If there is a AMD, we can think of giving anti-VEGF 1 to 2 weeks prior to cataract surgery, of course, after explaining the guarded visual prognosis, and second dose 1 month after previous dose. If you are following PRN protocol for treating patients with anti-VEGF, have a sufficient exudation-free period prior to cataract surgery, and follow the patient up closely should the membrane come back. If you are following treat and extend protocols, then closer follow-ups with monthly injections in post-op periods before then you again start extending. So you collapse your, follow-ups, and then again you can start extending in post-op period. So take-home messages: detailed fundus examination. There is no substitute to it. Prior to cataract surgery is a must. Correlate visual acuity and grade of cataract. Look at the status of the other eye. The modern optical biometers will give you information about the macula. Look at that picture before just looking at the power of the IOL that you are going to put. Ultrasound is a useful tool in large macular lesions when there is a total cataract or you have very poor view. Premacular hemorrhage may be caused by other pathologies, not just AMD. So, after the webinar, I would like everybody to remember that there are other pathologies which can cause large macular hemorrhage, and management of retinal pathology should precede cataract surgery. And we have to give guarded prognosis before doing cataract surgery. So even if you're doing wonderful cataract surgery, patient may not be able to see well to their satisfaction, and we have to explain it preoperatively. So to have happy patient, or at least not unhappy patient, and protect ourselves medico-legally. Thank you for your kind attention.
Fantastic, Manish. Fantastic. Excellent presentation. And I think your take-home messages are absolute pearls. So the most important thing that was, apart from the other presentations and take-home messages that we already had, is the importance of immediately referring a large macular hemorrhage to the vitreoretina surgeon. And it is his domain and absolutely not the cataract surgeon's domain at all. So immediate referring, the ultrasound, which you very well stressed, the ultrasound at times for a cataract surgeon is being done by technicians also. So this should not be the right approach, because the ultrasound can actually take up the macular part, as well as if there's a macular swelling and a possibility of macular pathology, as well as the optic disc also. The cup disc can also come up during a good ultrasound, and it needs a good ultrasoundologist to do it, which of course is the cataract surgeon can do it himself, or a VR surgeon can do it himself. So having said this, let's go to our discussants, Mallika and Dr. Hemant Murthy. Sir, for your comments, please.
Yeah, an excellent talk. I think he has stressed everything very rightly. I would say that he has covered what is very important, that is the preoperative assessment with an indirect ophthalmoscope. Try to see the fundus. If it's not possible, are you sure that the cataract, the vision loss is commensurate with the cataract? First, you have to make out that. I was checking the other eye is very good point that he made. The use of preoperative investigations like OCT and ultrasound helps you a lot. I do my ultrasounds, and I find that you can at most times tell the patient what's going wrong in the retina. So if the media is so hazy that you cannot do an OCT, then ultrasound should help you out in these cases. And also one should remember that all hemorrhages are not due to AMD. So there are various retinal pathologies that you should remember that would cause a problem. And these should be investigated by the retinal surgeons, as you rightly said, and we should go forward with that. Ultimately, patients, it should be for the patient's benefit that we should all work towards as a team. I think we need not be in our own domains. Retinal and cataract surgeons are now should be part together. Only then we get good vision.
Absolutely.
And the other point that I wanted to ask, the interval after cataract surgery, Manish, would you wait for 1 month? Is it, you could give it even earlier, because nowadays you do so wonderful cataract surgery that your wounds are so stable that you can do a PRP after 2 weeks.
So this patient was 2006. This was
No,
this was very old.
Not for that patient, but I think
now I would probably treat it much earlier than a month. Yes.
That's right.
Malika?
Yeah, actually, I'm not the discussant for this talk. So I'm the discussant for the next one. But I think nothing more to add. Already very well described by Dr. Bapai and then Dr. Murthy.
Can I add one thing, Pata?
Yes, please.
No, you're talking, Manish. I think a lovely presentation, Manish. I just want to, when you have a vitreous hemorrhage and you're finding it difficult because you don't have the red glow, what I would suggest is there are two areas, two stages wherein your red glow is very necessary, not during the nucleus removal, during the capsulorhexis and during the cortical aspiration. These two times you need the red glow much more. So what I would suggest is put on the oblique illumination or ask your assistant to hold the endo illuminator. So you will have much better view. That's what I do. When I have a vitreous hemorrhage, when I don't have a good red glow, then I ask, put the oblique illumination on the microscope, or otherwise more effectively, just ask your assistant to hold the endo illuminator only during these two stages, during the cortical aspiration and during the capsulorhexis.
I think now Shishra has got
Dr. Mohan, instead of an endo illuminator, if the surgeon doesn't have an LED torch, would it work?
Can I add
powerful
something?
LED torch.
LED will not have that focus, no, like the endo illuminator.
Can I add something to this?
It is described to put in a chandelier.
A cataract surgeon won't have an endo illuminator. He won't have a chandelier.
No.
Cataract
Can I
surgeon
add
won't have
something?
access to this.
Amit, can I add something?
Yes.
Why not do it in a two-stage? Remove the nucleus, do the vitrectomy. You have the good red glow. Remove the remaining cortical and put the intraocular lens.
That's what many Americans do. But in a combined surgery, I tell the cataract surgeon, do everything and get out.
Same thing I do.
All my cataract surgeons are trained to do.
That will be much helpful. And you will be more safe. You can preserve, because the most important point is to preserve the posterior capsule. So if you have the good red glow, you can put the intraocular lens later on once the vitrectomy has been done.
Any other jugaad if you don't have a chandelier or an endo illuminator?
No, but with the chandelier, if vitreous hemorrhage is there, you will not get the good red glow until vitreous is not cleared.
Okay, now suppose like what
Chandelier, no, not chandelier or the endo illuminator work.
Manish wants to say something.
Yeah, Manish.
Yeah, I one point in either of these cases, at least keep a 3-piece lens ready when you know.
Absolutely.
So make sure that your anterior vitrectomy is working well and keep a 3-piece lens ready.
Every combined case with a VR surgeon, I always keep a 3-piece ready. I am sorry to say, I don't know PC ko kahan chua hai, VR surgeon ne humko nahi malum. So
correct. No. If you are doing cataract as a prior, for media clarity, so that you are doing, or as a combined surgery, it's good idea to have a 3-piece lens ready so you can put it in sulcus.
So in a combined surgery, so you can just put a chandelier, like make one port, put a chandelier, let the cataract surgeon do his job, and then continue with the VR surgery.
That's true.
Very true.
That's very true. I think that
Veer is getting ready. Veer is getting warmed up. So Amit, let's invite Veer now.
Yeah. So I invite next scientific speaker, Dr. Veer. And to introduce him, we have our scientific committee member, Dr. Somshila. Yeah, just 1 minute.
He's the youngest faculty here today.
Yeah.
We have a set of all young faculty, sir, including you.
Me, no?
But seriously, excellent discussion. Excellent. Dr. Somshila, over to you.
Yes, I'm ready. Thanks once again, Amit, for sharing your screen. And again, today I have the distinct. Yeah, I think the screen sharing is on now.
No, not yet.
No, there is
can't see.
Shall I share my screen if not?
Done?
No.
Yes.
Can you see the I shared already?
Yes.
So as pointed out, Dr. Veer Singh is our youngest faculty for today. So not the last and certainly not the least. So he has
just excuse me,
The
just 1
screen
minute.
is on, screen is-
There's some issue. Just 1 minute, yeah. Because
I think as well. If you like, I can.
Amit, you need a retina surgeon to help you.
No. Cataract part, I won't need anybody. Yeah, now it is okay. All over you. Sorry.
So not only is he the youngest surgeon, but there's quite a familial lineage of renowned family members for Dr. Veer Singh. He has multiple degrees to his credit, having done his fellowship at Shankar Netralaya in Chennai, and also having done the FICO Retina from London, UK. And he happens to be the great grandson of Dr. Sohan Singh, and after whom the hospital is named. Everybody knows such an illustrious grandfather that he has. He's the son of Dr. Preetam Singh and also grandson of Dr. Ranbir Singh. So apart from the family legacy that he already has, which only makes it more difficult for him, I think, they're all fourth generation ophthalmologists, as is obvious. He, in his own right, is an excellent vitreoretinal surgeon, and he's also a cataract surgeon. So he's perfectly suited for today's meeting. And he does both of these at the center in Amritsar. He did his MBBS from the KLE Society Jawaharlal Nehru Medical College in Belgaum. Again, being very young, he did it just a few years ago, 9 years ago, and his MS Ophthalmology from Meerut. And he had topped his batch there also. So you can see that he's maintaining the illustrious lineage that he comes from. So he, apart from doing many other surgery fellowships, he also has done a FICO fellowship from Shroff's Charity Eye Center in New Delhi. Again, over to Dr. Veer Singh for his case presentation.
Veer Singh, very happy to be your Facebook friend now. And I think the entire family is close to me.
Again from Jain Medical College, Belgaum. Happy to share that.
And Veer Singh, I don't know whether you remember, I've come and spent holidays with your parents.
I know, sir. An interesting fact, sir, Dr. Srinivas was he's a postgraduate at Belgaum when I was a third year MBBS. So he taught me ophthalmology back then.
Very good. Lovely college.
But today he knows much more ophthalmology than me, sir.
Now that's good, no?
Yeah, that's what is expected from a junior.
Yes. We have three alumni from Belgaum now.
From Shankar Netralaya, man.
Who is that one?
Okay. I am from Belgaum, Jain Medical College. I am the father, the senior most.
Amit, yeah, I know.
Okay, over to you, Veer.
So before I begin, I'd like to thank Partha Bishwas sir for the entire team at AIOS and the expert team of panel for having me here. So I've been given, I think, a relatively simpler topic, I would say, which has much less treatment dilemma, subretinal hemorrhage. And I'm going to be presenting two very simple cases from a retina surgeon's point of view. And each of these cases, both of them are not AMD. One is an AMD related and one is a different pathology. And I'll come to them and probably have a good discussion by the end, because treating a subretinal hemorrhage has pretty much is on the same lines, other than an adjuvant anti-VEGF for other conditions as well. So the first case was a 53-year-old female. She was a known case of hypertension since 12 years. She had a sudden drop in vision in the left eye since 2 days. Her presenting visual acuity was counting figures close to face. She had a grade 3 to 4 cataract, which you can see here that the fundus picture is quite hazy. And the OCT was also was taken with great amount of difficulty, but it showed a clear subretinal hemorrhage. If you can see a small lesion near the superior arcade. So it was diagnosed as a case of ruptured RAM with a submacular hemorrhage. Now, the options discussed with the patient were either to go with the pneumatic displacement followed by cataract surgery or combine the both. But then patient revealed a history of PIVD, which is a prolapsed intravertebral disc, and expressed the inability to maintain a prone position. Keeping in view of that, we advised a combined surgery, which is a phaco along with a vitrectomy, subretinal TPA, air, and a SF6 tamponade. GVP was very clearly explained to the patient. But I think the patient had some dilemma in mind, and probably there's a general consensus, at least here in Punjab, ke most of the things is because of vision drop or cataract hai. So the patient did not report back. Patient underwent phaco procedure elsewhere and had no visual gain. That's when the patient went to PGI seeking a second opinion. And lucky for me, he ended up with a close friend of mine, Dr. Mohit Dogra there, who ended up getting in touch with me, and we had the opportunity to treat the case together. So the vision was still counting figures, but the fundus picture was definitely clear because the cataract was gone. Submacular hemorrhage still remained, and the OCT was something like this. So we decided to go in for a surgery, and the surgery was basically because the prone position was an issue. We decided to go with a 25 gauge subretinal TPA air and a SF6 tamponade. So this is what the surgery was done by Dr. Mohit Dogra at PGI. After making 25 gauge ports, a complete vitrectomy was done. And once the vitrectomy is over, the subretinal hemorrhage was again inspected, and a superior nasal site was selected to inject. This is a 41 gauge Med1 subretinal cannula through which 0.3 ml of TPA along with 0.3 ml of air was injected. Followed by again a reinspection and a fluid exchange. After fluid exchange, SF6 20% was given, and the case was closed. So on POD3, the hemorrhage had significantly shifted inferiorly, and the vision had improved to 160. And at 3 months, the vision improved to 618.
Fantastic.
The second case was a 59-year-old female with a sudden diminution of vision in the left eye since 3 days. Now, the vision was actually just a second, was 6.9 in the right eye and the left eye, counting fingers, and the patient had a grade 2 to 3 nuclear sclerosis in both eyes. The right eye had drusen. The OCT was somewhat in a near normal macula with a bumpy RP. The left eye had a frank subretinal hemorrhage, a massive one, and which could be seen in the OCT itself. So the case was diagnosed as a dry AMD in the right eye and left eye wet AMD/PCV with a submacular hemorrhage. Now, the treatment here, what was given was an injection of Avastin along with a TP and a 0.3 ml of pure SF6 gas followed by prone positioning. Unfortunately, on third day of the injection, patient came for a checkup and he had a breakthrough vitreous hemorrhage, which was seen in the first image shows a submacular hemorrhage and a vitreous hemorrhage on the ultrasound. So looking into this, surgery was advised. So again, surgery was done, a combined surgery was done, a phaco with a vitrectomy, subretinal TPA. In this case, subretinal Avastin was given, but air was not injected, and a SF6 tamponade was given, followed by prone positioning. Then monthly injections were given, and at 2 months, the visual acuity had improved to 624, and at 3 months, it had improved to 618. So these were the 2 cases, but I just wanted to say a couple of lines on some articles that I came across. The first one is specifically related to AMD, in which they showed that the vitrectomy and the subretinal TPA with the Avastin has the best outcome, but even the intravitreal injection of TPA with the Avastin had comparable results. In the second study was about not about AMD, but about traumatic subretinal hemorrhages, which showed that the vitrectomy with subretinal TPA had a superior outcomes. But if there was no availability of an expert surgeon, it was better to do a intravitreal injection. So this is a chart I've taken from the same study. So this says if it's a young patient, probably a good idea to try a pneumatic displacement with a prone position in the first go. And if it's an old patient and there is no other comorbidities, you have an expert vitreal surgeon, good to go for a surgery. If there is the surgeon is not that well versed with the subretinal surgery, you can have a TPA intravitreal injection with gas tamponade. And with an AMD, you can have a adjuvant anti-VEGF injection. So, and this is another article published in 2016 by Professor Atul Kumar, which I'm particularly fond of, and I follow this with the subretinal surgery, which is injecting 0.4 ml of TPA subretinal and double dose of Avastin, along with a subretinal 0.3 ml air and SF6 tamponade. So the key points when dealing with subretinal hemorrhage and cataract together is the best time window is better within 7 days or maximum to a 10 days interval, because articles have shown that even in 24 hours, the damage, the photoreceptor damage starts happening. Aim is to always prioritize the subretinal hemorrhage over the cataract surgery. Options could be treat the subretinal hemorrhage if view permits and do a subsequent cataract surgery, or combine the two, either with a pneumatic displacement or with a subretinal surgery, or do a cataract surgery followed by a pneumatic displacement or retinal surgery within that 7 to 10 days time period. Never delay subretinal hemorrhage treating subretinal hemorrhage over a cataract surgery, because then the real purpose, that is visual restoration, is defeated. always have a realistic visual expectation, counsel the patient accordingly, never ever overpromise. I'd like to acknowledge Dr. Mohit Dogra from PGI and Dr. Saveen Gupta from Poly Hospital, Ludhiana, who contributed to this presentation. With that, I'd like to thank you and open the discussion for these cases.
Fantastic. Excellent. I think all of us are clapping, Veer, for you, and excellent presentation and beautiful show of the cases. So without much ado, we'll have Dr. Mallika and Dr. Rajiv Chaudhary, sir, to comment.
As far as the cataract surgery are concerned, that if you have the early cataract also, try to do in the same stage. For the retina point, Dr. Mallika can comment very well.
Okay, so in this situation, Dr. Chaudhary, I would like to disagree with you because this is an emergency. Here we are dealing with a submacular hemorrhage, is not like dealing with AMD usual. So I don't think an early cataract is going to be operated at this time. We have to get the blood out of the macula. That's the priority. Absolutely. Only if we can't see, if the cataract is so advanced, which is unlikely, only then we need to think about the cataract. Now, in your first case, Dr. Veer Singh, very good cases. In your first case, very well removed hemorrhage, but was the retinal macroaneurysm addressed with the focal laser or something after the surgery? Because it would bleed again. So,
nothing was done to the RAM.
So that should be done. I just wanted to say that after you have cleared the hemorrhage, now you can call the patient anytime and just laser the RAM.
Just a point. A lot of times RAMs, after they rupture, they kind of scar down there and they never bleed again. So that was what was in mind.
Not so. Okay, fine. But the treatment should be for RAM should be laser as well.
Laser.
Second thing is that breakthrough hemorrhage is expected when you are treating a large submacular hemorrhage. We have to tell the patient that this blood can spread out, and in fact, what peripheral vision which you have may also go away after my pneumatic displacement. So that is not an indication for surgery. That is an expected outcome of pneumatic displacement. I always tell my patients, and that happens. It does break through, but the indication for surgery only would be if you can see that the subretinal blood has not cleared because of the PD, which you did document in this case with a B scan. You showed that it had not cleared. So if you can document that subretinal hemorrhage is still there, either on OCT, if media allows, or B scan, then only you have to go for the next step, which is surgery. But if that has been, if the height has reduced on B scan, you can just observe. And the ultimate idea is that the final visual outcome will be better because you have removed the submacular hemorrhage. Vitreous hemorrhage is not an issue that can take its own time and clear. And most of these patients can recover good vision. And the third, sorry, yeah, tell me.
So in this, the only thing is that normally we wouldn't do a B scan in a clear media. So we don't have any comparative analysis to do, when we see a subretinal hemorrhage. So not wanting to leave it to chance was the idea we want.
You brought in a very good point. Now in anticipation, you should do a B scan before you inject, before you do a PD, so that you can compare.
True.
You should do an OCT and a B scan because you are anticipating a breakthrough hemorrhage. That is not a surprise. Third point is that if you are injecting anti-VEGF with the TPA intravitreally, then avoid aflibercept. That has been shown to have a drug interaction where aflibercept can become less effective. And here I would also like to point out that every case that you see with submacular hemorrhage does not need a gas also. With thin submacular hemorrhage, I have got away with very good vision with just anti-VEGF for the AMD or whatever is the cause. And you get very good vision, and that is documented in many recent papers. So you don't have to give in a gas. Gas is given when you have reasonably thick hemorrhage which you want to remove. And that I think works only for the first 5 to 10 days. And in every case, if you can give an intravitreal TPA with a gas, that's always good because large number of cases will clear. Only a small proportion will go to submacular TPA and gas injection required. And if you do a submacular TPA, then you have to keep the patient supine for a few hours before you put them face down so that the TPA can act on the clot before the patient can go face down, prone position.
We do that when giving injections as well. We tell the patient to lie supine for the first 2 hours and then do prone position.
That's right. That's all. These are the points, but otherwise very
I
good.
would,
Can I ask one question, Malika?
Can I add a point?
Yeah.
One of the points was that for the RAM, the best way to assess is after the media has cleared and the hemorrhage is cleared, do an fluorescent angiography and check whether the RAM is open or is it closed, like what you said. Generally, most of them thrombose on their own. So you would not need treatment. So all RAMs don't need treatment. So it just depends on what it is.
Like can you please tell what is the full form of RAM for the anterior segment?
Retinal artery macroaneurysm.
Thank you.
Yeah. The second point is whenever you have breakthrough hemorrhage, like what he showed, generally it becomes like a khaki colored vitreous. It's actually very thick vitreous. And generally most of these vitreous does not clear. So a lot of patients do end up with needing surgery rather than they waiting. It doesn't help because it always has a very different texture. You would always see a very thick vitreous. And when you do vitrectomy, you see a very thick vitreous. Actually, once you start doing vitrectomy, you can tell that there's a retinal pathology just looking at the vitreous.
The khaki color is because of the duration of the blood, but that does not mean that it will not clear. It's not organized vitreous hemorrhage, which we get in a long-standing vitreous hemorrhage. So
generally, the course has been that most of them do require some intervention. Some of them do.
I've never had to do a vitrectomy to remove that obstruction. Never. Within a month, they clear.
So, but it's very important to look at the OCT before you inject subretinally, because many a times if you have a big sub-RPE component and a small subretinal component, then there is no point injecting subretinally. That is very important. Secondly, what I do is, in such cases, I don't do a complete fluid gas exchange. I do about a 60 to 70% FGE. And then leave it, because you want the lower retina to be left without gas so that the hemorrhage can be literally pushed towards the inferior side and not locked at the macula. Many times if you do a complete fluid gas exchange and you put a expansile gas, your liquefied blood also can sort of get locked against the posterior pole. So if you leave do a partial FGE, then you have that much space down for that blood to escape inferiorly and not come back or get locked into macula.
But I
think
that's
important too.
Yeah, 2 points I would like to make here. The sub-RPE hemorrhage, that's a very good point you brought up. If you have sub-RPE hemorrhage, I think even the surgery is no use, because there
no use. Absolutely.
So surgery should not be done.
Not be done. That's why the OCT is so important, and that's why even the thickness of the hemorrhage is important, rather than how much hemorrhage you see directly. Because on OCT you might find that it is just a very thin film, and like you said, Malika, you can just get away by a normal anti-VEGF.
Now, the other
on the OCT. So in such submacular hemorrhages, I think doing a good OCT.
Amit sir, can I just add a point?
Yes, yes. We'll take your last comment from you and we'll go to the next case.
I think I agree with what Malika madam said. Chaudhary sir, what we do usually in cases of these submacular bleeds, especially if there is a CNVM underneath, then doing cataract surgery early, the patient will definitely be disappointed. So most of the studies have shown that usually they wait until the cataract becomes so dense that after removing the cataract, they will have a little bit of peripheral vision. That is increased illumination from the periphery that will try to give them a little bit of illumination. Only if it is obscuring your macular surgery, as Veer nicely showed in his videos, that if you use a 42 gauge syringe and try to inject it, if you have a dense PSC, and if you're not able to see the macula at all, though you are able to see the periphery, then that doesn't serve the purpose. That is where we have to do a cataract surgery and then go in for the macular surgery. Now, the second point is, I agree that if there is a thin film of blood and it is restricted to the posterior pole, we can always go in for non-invasive techniques like a pneumatic displacement and with the intravitreal TPA. But when you decided to go ahead with the vitrectomy, if it is extending beyond the arcades, it's a massive subretinal hemorrhage, then instead of giving intravitreal injection after doing vitrectomy, I would rather suggest to go in subretinal TPA, because subretinal TPA gives wonders. I've seen in my 12 of my cases that it does wonderful results giving a subretinal TPA in case you are doing a vitrectomy. But as madam said, if it's not that thick, if it's a thin film and young patient, you can still go ahead with the pneumatic displacement with intravitreal TPA.
Thank you, Srinivas. Now we go ahead with the last case because it's already
last comment. Mohan,
one question,
yeah.
Amit.
Yeah.
Yeah. I just want to ask Mallika and Veer, a fantastic presentation. There are different modalities of treatment for the submacular hemorrhage. So whatever we have discussed now. So when to do what? That is what is the question I wanted to ask. When will you give only anti-VEGF? When will you combine TPA with anti-VEGF and gas? When will you do submacular?
Yeah, so I already said that when you have a thin film of blood, then you can get away with anti-VEGF.
Yeah.
If you have a relatively thick clot of blood and it is fresh within 10 days, you can go with pneumatic displacement in addition to intravitreal TPA and anti-VEGF if you want, depending on the etiology. And if your PD fails or the patient has come to you after 10-15 days of the bleeding, then PD will not work. The clot would be too hard. There you have to, or if the PD has failed even in the early cases. In these two situations, you go for surgery where you do subretinal TPA and gas and then prone position.
Okay.
And then there's a fourth point. Supposing the blood is primarily superior and the fovea is barely involved, but mostly superior. Now here you should not do a PD because you will push most of the blood into the fovea and you will have a disaster. So here you have to operate and you have to evacuate that blood on the table, not keep TPA there and prone position, remove the blood, put TPA, wait for 15-20 minutes, allow the blood to liquefy and then aspirate the blood from the subretinal space and then put gas so that you come out with a clean fovea.
Absolutely.
Just one last one. Since, I mean, this is an AMD, we are discussing AMD. I think we've not mentioned the point scarring here. In case there is scarring, I think nothing is going to work. So just plain anti-VEGF. So that is one thing I think we should keep in mind.
And the last point before you close is that, like Mallika said, if there is hemorrhage only and it's sub RPE, then there is no point in doing any of these. So you have to, now you have about 5 points.
Yeah. Instead of 3, it has become 5 now.
Thank you, everybody. Now we move to our next case, Dr. Pooja Sinha. This is the last case of the webinar. And to introduce her, we have our scientific committee member, Dr. Balla. Dr. Balla, over to you.
Yeah. I think wonderful discussion we had. Now it's my pleasant duty to introduce the last speaker of the webinar, Dr. Pooja Sinha, who is young and dynamic VR surgeon from Patna. She did her MBBS from Mahai Institute and diploma in ophthalmology, fellowship in VR from Shankar Nethralaya, Chennai, and she was trained at Stanford University, USA and Oxford University, UK, Hull, UK. She has been awarded Dr. D.K. Bose Gold Medal, and she is specialist in lasers and surgical and medical retina. She is key person in ABI Institute for conducting monthly CMEs, which are very popular. Over to you, Dr. Pooja. Stage is all yours.
Thank you very much, Balla sir, for this kind introduction. So a very good evening to all of you. Am I audible?
Yes.
A very good evening. I would like to thank Partha Biswas sir and All India Ophthalmic Society for giving me this opportunity. I'll be presenting a very challenging case of ARMD. Up until now, most of the action has been happening in the macula, but I'm presenting a case with action happening in the mid-periphery in contrast to other presenters. So here is a 68-year-old male patient with diminution of vision in the left eye for 1 month. He was a diabetic for 5 years. Recent glycosylated hemoglobin was 6.8%. There was no other significant systemic history. On examination, the vision in the right eye was 6/12 N12 and left eye was 6/24 N18. Slit lamp examination revealed grade 2 nuclear NS in both the eyes. So this is the picture of the right eye, which showed multiple drusen in the posterior pole with little bit of ILM wrinkling and few microaneurysms showing the mild non-NPDR changes in this patient. In the left eye, there were few microaneurysms and a large clot hemorrhage in the macula. There was a thin rim of subretinal hemorrhage at the temporal border of the macula. A massive dome-shaped peripheral hemorrhagic subretinal lesion was seen in the inferotemporal quadrant, which was both sub-RPE as well as subretinal. So the FFA showed leaking macroaneurysms, blocked fluorescence corresponding to the subretinal macular hemorrhage. There was blockage of choroidal fluorescence below the hemorrhagic mass. There were surrounding window defects from atrophic RPE changes. ICG was also done, which showed a very small hyperfluorescent polyp in the superior part of the hemorrhagic mass. This is the macular picture, which didn't show anything significant. This was the line scan through the hemorrhagic mass, which showed the subretinal hemorrhagic heme with little bit of subretinal fluid and intraretinal edema. So I diagnosed the case as PEHCR, that is peripheral exudative hemorrhagic choroidoretinopathy or peripheral IPCV. Injection of ranibizumab 0.05 ml was given, followed by laser around the hemorrhagic mass after a week in August 2018. The injection was repeated in a monthly interval over 3 months. So the hemorrhages had significantly cleared after the second injection. Few NPDR changes were remaining. There was a good scar around the mass-like lesion. And the vision had improved from 6/24 to 6/12 after the third injection. Again, the patient reported in February 2019, when the vision was 6/12, there was a thick band of subretinal hemorrhage surrounding the previous lesion. At this time, 2 more injections of ranibizumab were given in February and March 2019. Post-injections, the patient was doing quite well. The hemorrhages had decreased. At the end of 2 months, the vision had improved to 6/9. The hemorrhage had subsided with subretinal fibrosis, and not much diabetic changes were progressing in the patient, which was lucky for him. The FFA showed large chorioretinal atrophic patches with dilated choroidal veins and window defects with stippling. But to his dismay and to my dismay, the patient reported in July 2019 with a sudden diminution of vision in the left eye. At this point, he had developed vitreous hemorrhage, which was a breakthrough vitreous hemorrhage. And at this point, we decided to do a phaco IOL surgery in him with vitrectomy and peripheral endolaser. Post-vitrectomy, the vision had improved to 6/9, and there was complete regression of the lesion with RPE hyperplasia and atrophy. But lo and behold, the patient has again reported to me a week back where he has dropped his vision to 6/60, sudden diminution of vision for a week. There's a large subretinal hemorrhage below the macula, abutting the fovea and extending inferiorly. And at this point of time, the FFA showed these small hyperfluorescent dot-like echoes, these polyps, polyp-like lesions, which I'm presuming could be the causative factor for this hemorrhage. So in conclusion, the peripheral exudative hemorrhagic choroidoretinopathy or PEHCR is an uncommon degenerative process of the retina with subretinal or sub-RP hemorrhage and exudative mass outside of the macular region. It was first described by Rees and Jones in 1962. Those two et al. Claim that PEHCR is the peripheral counterpart of ARMD, but drusen is the hallmark of ARMD, and that is mostly absent in PEHCR. The visual loss could be due to subretinal fluid, subretinal hemorrhage, or fibrosis. Breakthrough vitreous hemorrhage could be devastating and cause sudden drop of vision in these patients. OCT is sometimes not necessary when clinically we can see that the macula is not involved, but sometimes subtle peripheral submacular hemorrhagic changes can be seen, which was very evident in this patient. Sometimes exudation in the fovea and subretinal fluid is important to diagnose and quantify with an OCT. Differentials are again very important in these kind of diagnoses. B-scan is sometimes important to differentiate PEHCR from choroidal melanoma, where we all know that in PEHCR there will be a clot retraction cleft which is present, absence of intrinsic double circulation which is seen in choroidal melanoma, and no choroidal excavation as is seen in melanoma. So a regular and continuous follow-up is required owing to the aggressive nature of the disease. So the take-home message in this case, I would say, is like we have all been discussing that 90D diopter examination may not be sometimes, it may miss certain lesions, especially this large mound of hemorrhage could have been missed if we just did a 90D examination, because we would just think that the patient is a diabetic and we would just see these small NPDR changes and macroorganisms and go ahead with the cataract surgery. So a 90D examination along with an indirect ophthalmoscopy is critical in these patients. And then I think also the role of aflibercept in these cases and PDT, as Professor Atul Kumar sir was so nicely mentioning, may play a role. Thank you so much for your patient hearing.
Thank you, Pooja, for a very nice case. Would like to invite Dr. Mohan Rajan and Dr. Nishikant Borse for the expert comments for this case.
I think it's a yeah. Well, Nishi, you can go first.
Nice, fantastic case, Pooja. Very nice presentation. Did you try to do an ICG in this patient? You know, because as
yes,
yeah, tell me.
I did, and I sent the patient for an ICG in the initial stages of the disease, but I couldn't see much. There was just a small leaking polyp, which I may have imagined, but there was something. A small leaking polyp was there in the superior part of the lesion. And what made me suspicious was that definitely subretinal hemorrhage was there in the peripheral part of the fovea. And this large mound of this hemorrhagic mass, which was sub-RP and subretinal, definitely had something to do with an IPCV, even though subretinal lipid exudation was not there in my case, which is so classic in IPCV.
So many of the PEHCRs, there has been a series by Shields et al. And even Mantel, which has shown that about 20% of these cases are having polyps when it is PEHCR. Okay, so obviously ICG is very important when you have such a case. And especially when you have a case like this, which is coming with recurrent bleed, then definitely it is an IPCV, which is manifesting in different ways. That makes this case so unique, you know. That's very nicely presented. The second thing is, just one more point is like, it's not that drusen's are not associated with PEHCR. The only thing is, whenever there's a peripheral growth, the drusen's are not around it. I mean, you can have associated AMD changes. There are about 20% of the cases in which there are associated dry AMD changes also, which are at the macula, and you can have a growth in the periphery, but you will never find drusen's around this growth, and that is so specific about this PEHCR. But one more question, just why did you do laser initially when you gave the ranibizumab?
So I saw that small leaking polyp, and I was just wondering, you know, what I can do apart from doing this thing, anti-VEGF. And there was a little bit of breakthrough hemorrhage. It was not very evident clinically, but there was a little bit of breakthrough hemorrhage. And I thought that if I clear the hemorrhage with an anti-VEGF and then do laser, I think it'll make my visualization better.
Okay, so I don't think I would have done much different other than avoiding a laser. I would have done an ICG again later once the hemorrhage is cleared, seen if there are any polyps and specifically lasered them, and that would have maybe prevented a future hemorrhage if at all. Dr. Rajan, any comment?
Yeah. No, I think it's a brilliant presentation by Pooja. Hats off to you for bringing such a rare entity. But I would like to know, ask you two questions. One is, definitely there is a role for ICG in this particular case. Number one. Number two is whether the laser was, I saw the laser burns were a little heavy in that area. Was it something to do with the recurrent hemorrhage there?
The first time there was that little bit of the media haze. It was not too much, but it was there. And that is why I think the burns took up to be a little bit more heavy than what I had anticipated. So, yes, I think that a large amount of blood scared me. And then I thought I would laser it also along with anti-VEGF.
Yeah.
So you went around the mass.
Yes, sir.
You went around.
One of the very important entity which looks just like this, behaves just like this, prognosis is just like this, is retinal vasoproliferative tumor. So that also is peripheral, that also is temporal, that also presents as sudden vitreous hemorrhage and is asymptomatic before that. So that is something we need to keep in mind. That also has exudation and retinal detachments. The only difference could be that the age that is seen more in younger and middle-aged people, this is seen more in above 70 years of age. But the treatment, I think she's quite right. What Dr. Sinha has done is to do laser for the lesion. In fact, the entire lesion, because that is what is advised even for the vasoproliferative tumor, which I have treated many of them, is just do a direct laser over the entire lesion and a little bit around it as well. If laser doesn't work, cryo works very well, double freeze thaw. And sometimes I've had to do surgery for the associated vitreous hemorrhage. And if these cases are missed, and if you don't do cryo, you remove the vitreous hemorrhage, but you don't do cryo for the original lesion, it will continue to cause problems like exudative RD, tractional RD, and finally lead to neovascular glaucoma. It is VPT is a blinding condition and has to be tackled with cryo or laser, the original problem.
Yeah, but in PHCR, this is not so peripheral to do a cryo. The unfortunate part
is quite posterior.
It was very
quite posterior.
So laser was relatively easier.
So like
I just want to make a point here, sir. Can I make a point? So the surgery in all these peripheral exudative, pathologies, because of breakthrough hemorrhage, if you're going for a surgery, these surgeries are a little tricky because, retina is very thinned out over the lesions. And during, if you get casual and you do a rough PVD induction, there's a lot of, chances that you get a break formation over there. So you have to be very careful there. And once a break forms, it's of course gratifying first to see that the blood is getting drained out from that break. But they don't seal very well because there is a lot of hemorrhage subretinal after the drainage also. And that can lead to PVR very frequent in the post-op period. So you have to be very careful during surgery in these cases.
So like what Nishikant sir mentioned, that series by Shield. So according to that, PHCR, 90% of the cases they reported were between the aura and the equator.
Yeah.
So I mean, what could this be just like an extrafoveal CNVM or a normal PCV? And I feel like secondly, maybe if the lesion, whatever lesion this is so posterior, an OCT through the lesion would really clear the doubts as to what it is.
So if you see her OCT, it does show a growth which is subretinal, like a CNVM. Okay. Now the problem with her case is that the location is such that it's on the boundary. You can neither say categorically that it's an extrafoveal CNVM because it's pretty away from the fovea, so it cannot be just called as an extrafoveal, and it is just around between the arcade and the equator. So I would still go with PHCR in this case.
What are other conditions you have to think of apart from VPT and PHCR?
Yeah, it can be resembling a melanoma. It can resemble a vasoproliferative tumor also.
Pseudomelanoma, they say. Yeah. Then
I think.
Any other condition?
Should we come to an end? Should we conclude this webinar?
It was fantastic, fabulous. Hats off to you all, Partha. And
thank you. So I invite Dr. Partha to give a vote of thanks, our Chairman Scientific Committee, and we all it's teamwork. And I request Dr. Partha to just conclude.
I think before Partha, I want to compliment Partha and Amit for the teamwork. I think wonderful teamwork. I think you brought the best out of every speaker, right from the keynote speaker to each speaker and also the panelists. I think I thought it's like a boring topic without even asking questions. I accepted, but I'm happy. I enjoyed every minute, and I
Thank you.
want to talk later. Great program. I think I learned a lot.
Thank you.
So, but one homework you have to complete, Partha. You have to promise that.
OCT.
Yes, we'll work on that. We'll work on that. That's true.
Sir, and thank you first and foremost for being throughout the whole webinar, staying till the end and giving your expert comments. So the first thanks is to you and of course to Dr. Maipal, Dr. Shobhit Chawla, as well as to Dr. Lalit Verma, who is an inspiration for all these webinars which we have on the retina component. He always gives his inputs on them. And of course, Amit, who has been my co-moderator. Thank you so much, Amit. And a lot of brainstorming, thought process, and everything has gone in with the whole team of the scientific committee. And that's how the webinar just came into being. Professor Atul Kumar has been as wonderful as he's always in his talks and his didactic lectures. But the expert panel of Dr. Rajiv Chaudhary, Dr. Hemant Murthy, Professor Namrata Sharma, Mohan, again staying till the end, Malika staying till the end, Nishikant staying till the end, and of course, Ajay, my best friend, he just rushed off to another webinar.
Where did he go?
to Bangladesh. He went to Bangladesh.
Oh my. Okay.
Partha, one bonus for you.
Tomorrow we have a webinar for Bangladesh.
Oh, Achi, okay. Achi is there with us with all her questions.
Achi has been attending all the webinars.
Yes, he's expert now.
The best thing, you know, is our
He's
presenters.
talking in Portuguese and I'm translating. Excellent webinar.
But our best thing was our presenters, the phenomenal presentations. I think each presentation stood out on its own merit. Excellent presentation, right from Vishal's to Srinivas's, to Parth's and Manish's, of course, and Veer. Of course, Veer's presentation was phenomenal, and so was Pooja's. So with all these phenomenal presentations went up on the discussions, and the discussions were so enlightening, so enriching that, you know, I think I'd forgotten most of my fellowship in VR surgery. I'm sure, Mohan, you will have to say the same thing, and we have replenished.
I'm not forgotten.
So it has been a great webinar. So a quick comment from any of you, please.
And before we take a comment from others, I have a small request.
Mohan sir into VR services.
Yeah, that's true. थोड़ा पैसा हमारे लिए भी बचा दो. Okay, before we conclude, one last comment from my side. Partha has taken the names of everybody. So before that, I would like to request Dr. Nishikant, like for the DR, cataract in DR, we had a summary of the webinar which we had put up on the group. I think if Dr. Nishikant can take up this, today whatever we have discussed, just the important points which a cataract surgeon should know. If you can just give a few summary of the today's webinar, I would say 10-15 points or whatever. I mean, so that the cataract surgeon can just take a printout and keep in his OPD. Okay, ARMD ka case hai, ye mere ko dekhna hai. So that will be a very good thing. We did it for the DR. Dr. Lalit Verma helped us for the DR thing. So I request Dr. Nishikant to just, if you can do in a day or two, like today's, you're tired, tomorrow you can just recollect the webinar, and you don't have to recollect, you know everything. So just you have to pen it down and you can pass it to us in the group.
Sure.
And thank you once again, the chairpersons, the AIOS headquarters.
I have a suggestion. Why not you ask Veer Singh to prepare and send it to Nishikant so he can polish it?
Whatever. I mean, it is a teamwork. I expect the whole thing to be in the group by tomorrow evening, 6 o'clock. So Dr. Nishikant is supposed to do, okay, if we can help Dr. Nishikant, well and good. It's a teamwork. That's what we scientific committee believe in. So once again, thank you all the chairpersons, the speakers, the moderators, the panelists, and the audience, Novartis, everybody over here. So any comments from anybody, welcome.
Yeah.
Thank you, Partha and Amit. As a good program. It is a combination of anterior posterior segment, and the patient comes. Does not he has an anterior segment problem or posterior segment problem. He is the patient. So
husband-wife problem.
Yeah. So everybody has to be aware about the posterior segment also, anterior segment also. So that's combination is required. So thank you for arranging a nice program. Thank you and all for a good presentation.
We have a with Alcon and PGI tomorrow morning at 11. We have a similar case-based program. So I just thought I'll let you know about that. It's on Retina, but yeah.
Thank you, Partha sir.
Last,
the real boss of scientific committee.
Thank you. Partha sir rocks.
Really a wonderful moderation by you and the entire scientific committee. Somshila Ma'am here. She's all smiling, and all the scientific members. You know, I am also an ARC panel member. So whenever a webinar goes like this for 4 hours, and rest of the members, apart from the moderators, the rest of the panel members who are sitting till the end, it's really a kudos to them. So I would like to congratulate entire team of the AIOS scientific committee for sitting all that end till, though retina might not be a subject to you all, but still you have stood by us. That's what we respect. Thank you very much, entire scientific.
Understood. Thanks to concepts from all of you. And Partha rocks here. Partha leads from the front like Dhoni.
Yeah, agreed.
Okay, but the last thanks is to Kripal and to our HQ office.
HQ. I mentioned HQ.
And to Novartis, who made all this possible. So a big thanks and applause to all of them.
Thank you, sir.
Enjoy, all of you, enjoy your Saturday evening.
Okay. Saturday evening is all finished. Yeah, it's 9 o'clock.
Evening is gone.
तो लग रहा है